Good afternoon. We'll start this session, which is dedicated to vasopressors and vasopressor choices. And I am Jean Teboul from Paris, and my co-chairman will come very soon. But we'll start anyway this session by the first presentation. The first presentation by Pierre Guinot from Dijon. And we'll talk about this title, which is More Fluid or Vasopressors.
Okay. So good afternoon. I'm Pierre Guinot from Dijon. And Honorable Chair, dear colleagues, it's an honor to be speaking with you this afternoon, giving more fluid or vasopressor. This is my conflict of interest. And to start this session, I would like to ask a question. What should I expect by using more vasopressor or more fluid to my patient? For many years, fluid and vasopressor have been used to improve MAP. But I think because we restricted tissue perfusion assessment to MAP, we believe that systematically giving fluid or vasopressor will improve outcome. But it's not true. And now we have many evidences that demonstrated that excessive use of fluid or vasopressor can be harmful. We have the fluid accumulation syndrome, and also with an excessive use of vasopressor, we can have ischemia of the heart, of the heart or mesenteric. But now we have an abundant literature evaluating the best fluid strategy. But these results are not significant. And it's why I think we should now use a personalized early start of norepinephrine in our patient, and particularly when we have a life-threatening hypotension, a low diastolic arterial blood pressure, or high ratio between the heart rate and the DAP. But we should combine this use to fluid. Because when you use both fluid and vasopressor, you can improve the effect of fluid while limiting their side effects, such as hemodilution or fluid overload. But it's not so simple. And I like this study because this study is an illustration of the balance between fluid and vasopressor use. So in this study, the author evaluated a pig model of sepsis shock, and they resuscitated the pig with fluid, but also with several doses of norepinephrine. You have a group with only fluid, and then you have fluid with an increased dose of norepinephrine from 0 to 1.6 microgram kilo per minute. And then they assess the effect of macrohemodynamic and also on microcirculation. On the left side of the slide, they show you the amount of fluid received during resuscitation according to the dose of norepinephrine. And we can see that less vasopressor you use, more fluid you give to the animals. And also for cardiac index and extravascular lung water, you have the same observation. But the lower cardiac index was observed when you do not use vasopressor in association to fluid. But the higher cardiac index was not observed for the higher dose of norepinephrine. It was observed for a dose of 0.8 microgram kilo per minute. And it's the same for extra-lung water and also for the microcirculation on the right side of the slide. At the lower and the higher dose of norepinephrine, you do not improve microcirculation. You only improve microcirculation when you use a middle dose of norepinephrine. And this result introduce for me a notion that is very important. It's a balance. We should not think in terms of more fluid, less fluid, more vasopressor, higher map, but in terms of balance. Balance between the blood flow and the blood pressure. And first, one important and key requirement is to always test preload dependency before giving fluid. I will not develop because we already had a lecture this morning, but we have many tools to do that. And why? Because according to this study, the author test passive level raising used systematically before giving fluid. And in case of a negative absence of change of stroke volume with the passive leg raising, they test vasopressor use. So you can see when you systematically use a preload test, you decrease the fluid balance of your patient. And also you decrease the duration of vasopressor support and ventilator support. And you have a trend to have a lower rate of kidney event and major advanced cardiovascular event. Now, regarding mean arterial blood pressure level and vasopressor use, we have two interesting reviews. The first one assess the lower versus higher map on outcome. They did not demonstrate any association between a high map and better outcome. But when you focus on patient treated for more than 6 hours with a vasopressor, it seems to have a better outcome, a lower death with a lower map. And recently, we have another review, a meta-analysis, assessing the lower or the higher exposure to vasopressor and its relation to death. And this meta-analysis demonstrated that a lower exposure to vasopressor was associated with a lower mortality. And it's particularly true in septic patients. It's why when I use vasopressor, I always think in terms of the balance between the blood flow side of the cardiovascular system and the blood pressure side of the cardio system. And also, I question myself about the need for vasopressor. And how I do that? I use this parameter, the dynamic arterial elastance. It's the ratio between the respiratory variation of the pulse pressure and the stroke volume. And usual value are around 1. So it can inform us of the balance between a variation of pulse pressure and a variation of stroke volume. So pressure, blood flow. And now we have many studies demonstrating several things. First, in vasoplegic patients support by vasopressor, you can use dynamic arterial elastance to predict an increase in blood pressure following a fluid challenge. As you can note on the top right side of the slide, some patients increase blood flow and blood pressure, while others only increase blood flow after a fluid challenge. And now we have this parameter to predict that. Also, we can use dynamic arterial elastance to predict a drop of blood pressure when you decrease the dose of norepinephrine. And in all this study, the threshold value is around 0.9 to 1. So later, you have a randomized study that evaluated and assessed this indice, the dynamic arterial elastance, to manage and to optimize vasopressor treatment. So what they did, they used an hemodynamic algorithm based on EADIN, and when iodine was over 0.94, they decreased the dose of norepinephrine regardless the MAP value. So, when you do that, you can decrease the duration of vasopressor support from 39 hours to 17 hours. And also, you decrease the duration of ICU, the ICU length and stand. And one interesting finding is that you do not give more fluid to your patient in the intervention group. So you do not use more fluid to win norepinephrine. And at the end, you have a slightly higher SVO2 value. So later, this author performed a post-hoc analysis, and they also observe that with this parameter, you have a lower rate of kidney event because probably of a toxic effect on the kidney of norepinephrine use. Now, to evaluate the balance between the flow and the pressure at tissue perfusion level, I think we should use capillary refill time because it was demonstrated to be associated to the blood volume, to the vascular tone, to endothelial function, to tissue perfusion. But it can monitor the response of the tissue perfusion to an hemodynamic intervention. And we have this small study that include septic patients with abnormal CRT at baseline, and they assess the change of CRT after a fluid challenge and also after a vasopressor test. And the vasopressor test consists of increasing blood pressure up to 80-85 millimeter mercury by increasing the dose of norepinephrine. And we can notice that the fluid challenge improves CRT. You have always a decrease of CRT. But the vasopressor test is associated to a significant change of CRT. But in some patients, the vasopressor test worsens CRT. You have an increase of the capillary refill time. So you may worsen the tissue perfusion by increasing the dose of norepinephrine. And it's why we can use this parameter to track change in tissue perfusion according to the dose of vasopressor of after a fluid challenge. And now I would like to conclude. And I will not conclude on more fluid, less fluid, more vasopressor, less vasopressor. I would like to move beyond this binary understanding by tailoring at each step of hemodynamic resuscitation the hemodynamic treatment by using parameters that inform on the balance between the blood flow and the blood pressure at macrohemodynamic level and also at the level of the tissue perfusion. Thank you.
Thank you very much. Thank you very much for this presentation, which is now open to questions, comments, suggestions, remarks, critiques. When you talk about more fluids or more vasopressors, or maybe less fluids and less vasopressors, of course it depends on the clinical context. If you talk about hypovolemic shock, if you talk about vasoplegic shock, combination, etc. So it depends on the context, of course. And to me, the way to think is, does this patient need fluids? Does this patient need vasopressors? That's it. So we need to have some indicators of fluid needs, I would say. Maybe fluid responsiveness tests can be used to do this. And also we need to have some indicators of need of vasopressors. And my question is about dynamic elastance, because you show that it could be used to decrease the dose of norepinephrine, okay? But can you predict with dynamic elastance the need of vasopressors?
No, you cannot. I think it's a big mistake and confusion in literature, and I milite against the use of elastic dynamic dynamic elastance to predict the use, because the vascular system is too complex, and when you use norepinephrine, you fix the vascular compliance. Thus, any change of pressure are now related not to arterial compliance, but most to systemic vascular resistance. It's why when you use this in patients support by norepinephrine, you can track change in systemic vascular resistance. And you have, to discuss a little bit, some study evaluating dynamic arterial elastance to predict an increase of blood flow and blood pressure in operating theater, but they are negative. Why? Because none of the patients were treated with vasopressor. And all positive study demonstrating that you can predict that were performed in patients support by norepinephrine.
Thank you. Questions? This is the beginning of the afternoon. Right.
Then we will be, for the first time, 4 minutes early. Thank you very much.
Thank you.
And to introduce myself, I'm Craig Cooper-Smith. I'm sure Jean-Louis has already introduced himself. I was actually on stage at 2 o'clock. Our next speaker needs no introduction. Jan Bakker has come all the way from like 5 or 10 minutes away to speak to us on what the options are.
Well, with traffic jam, sometimes it's longer than this. So, indeed, we have decided that we have to use vasopressors in a given patient. And then, of course, the questions that we will address in this talk and in other talks during this afternoon will be, which vasopressor can we use at the bedside and for which reason? If we think at how it really acts, we have basically, for leading to vasoconstriction, several mechanisms, but these are ultra simple, which are indeed increasing the intracellular calcium as a level of the vascular smooth cell, and this is under the influence of a G protein, which is itself stimulated by 3 receptors. Alpha-1 for the adrenergic vasopressors, V1 for the vasopressin system, and angiotensin II for the angiotensin system. So interesting, of course, these are the 3 receptors that we have on our cells. So it means that these are already implicated in the natural response to hypotension, where we will synthesize these different substances to stimulate and to try to reach some blood pressure. So the question will be, can we add some extra stimulation to any of these receptors to try to reach a higher blood pressure or the blood pressure that we want to target at the bedside? And of course, you can also consider giving calcium, but this is not really an option in our patient, even though the calcium channels are sometimes inhibited, and especially in sepsis and in acidotic situations. So we indeed want to use some vasopressors. The difference between the vasopressors will not really come from the stimulation, because the downstream mechanism is exactly the same. So the difference will come between the different vasopressors in a given patient because of the density of these receptors, which are sometimes internalized due to whatever mechanism, to the density within the vascular system, and these are not equally distributed. And also, importantly, the extra stimulation of other receptors, not really acting on vasoconstriction, but like the beta-2 receptor, beta-1 receptor, the V2 receptor, and other angiotensin receptors, all perhaps influenced by the exogenous administration of our vasopressors. So, indeed, the first vasopressors that we consider is indeed the norepinephrine, and this is based on many trials. This was one of these, and more recently, we indeed were going a little bit more in depth to these findings by performing some additional analysis, because indeed we just have the initial finding, a borderline signification, just failing to reach a significant difference between the two compounds, a significant difference in a predefined subgroup of cardiac shock, and more arrhythmias, whatever the type of shock indeed in these patients. However, as we mentioned, we performed with Fernando Zampieri some additional statistical analysis to try to better understand whether there could be some situation where where dopamine basically may perhaps still be considered compared to norepinephrine. So first, by doing just a Bayesian analysis for mortality, in most of the situation, indeed, norepinephrine was better compared to dopamine, and if we combine even mortality and the need of renal replacement therapy, there was no situation in which dopamine was better. It was each time better to have norepinephrine in this condition. If we also looked at the heterogeneity of treatment effect, it was quite interesting to realize that it was never in favor of dopamine. It was always in favor of norepinephrine or neutral in some situation, where indeed it was multiple combinations of age, type of shock, presence of cardiomyopathy, SOFA score, and also heart rate. So even in so-called bradycardic patients, norepinephrine was better than dopamine in this situation. So when we do meta-analysis, we also have some benefit from norepinephrine. When you also see what occurs in US when there was some shortage of norepinephrine, a lower use of norepinephrine, a higher use of other vasopressor agents, and at the same time, an increase in mortality in these centers. You may say, okay, they were not accustomed to handle the other drugs, but maybe there is a signal there that also norepinephrine might be the best for these kind of patients. But the question is, what can we do when our patient seems not to respond to norepinephrine? So we may consider, of course, to use other adrenergic agents. But this is not a very good idea because, indeed, stimulating the alpha receptor, which is already not responding, by another alpha stimulating agent will not be better. And we will have a higher stimulation of the other receptors. And this is indeed what occurs when you give, like, say, epinephrine in these conditions, and then, of course, you will not have anything more for the alpha, but you will have a lot of the beta stimulation, and this may have some impact, especially on the heart of this patient, but also on the peripheral system. On the peripheral system, and especially for the splanchnic area, it is really worse to give epinephrine than to give norepinephrine, with poor splanchnic perfusion. And if you also look at the outcome studies like this one, you have, of course, minimal impact on the survival. Of course, not enough patients were included in that trial, but perhaps even more importantly, there was initially a mandatory use of a beta-2 stimulation by the butamine. Whatever the cardiac output of these patients, this was per protocol. And then after some time, the beta-2 stimulation could be stopped. But so, of course, it's probably better to go just for norepinephrine, as we mentioned before. And even here, the other CAT trial that was indeed not showing any difference in mortality, even though there was some difference in heart rate and pH and other things like this. Remember that a lot of patients in the adrenaline group were withdrawn because indeed they experienced adverse effect. So indeed, if you stop to administer the drug because you have an adverse effect, in the patient who tolerates the drug, yes, you may have similar outcomes, even at the expense, of course, of increased heart rate and other things like this. And in cardiac shock, when the situation is even more complex, you have even an increase in the rate of refractory shock, an increase in the risk of death in these conditions. So everything goes in opposition to the use of epinephrine as a salvage, and that's why probably not a good option. So what else do we have as an option? Vasopressin probably is one of the best one. Of course, we have the VAS trial. The signals here that it was at least as good, if not even slightly better. Of course, in the level of the low norepinephrine doses, there was clearly, in this predefined subgroup, an improvement in outcome. Unfortunately, the other trial, which was using very early administration of vasopressin with, unfortunately, also a low dose of norepinephrine in these patients at randomization. This was totally negative and even going the other way around. So we cannot say that systematically using one drug versus the other one will give any advantage. Indeed, in terms of mortality, no real difference. However, it doesn't mean that the drugs are equivalent. And there are probably some patients who benefit from the drug and some patients who were harmed. So how to detect who may benefit? Well, probably looking at patients with renal dysfunction, because indeed there is less requirement of renal replacement therapy in the patient treated with vasopressin. Also, patients with arrhythmias are probably also helped by the early use of vasopressin in these conditions. And also, of course, we need to pay attention to specific conditions. And especially when you have left ventricular tract obstruction, which occurs in roughly 20% of our patients with septic shock. In these conditions, yes, indeed, administration of vasopressin results in a decrease in the heart rate, a decrease in the gradient inside the heart, a decrease in the lactate, and this may, of course, be really considered in these conditions. Well, of course, there is some adverse effect, and there was a lot of emphasis on the skin ischemia, but do not forget the splanchnic ischemia, and this can be especially observed when you try to reach a bit higher doses, because indeed higher doses are more useful to try to increase blood pressure, okay, but you have more decrease in cardiac index, you have also more increase in transaminase, you have also especially more increase in other things like this. So everything seems not to be always in the good direction, especially in the splanchnic area of these patients. We may also consider, of course, the use of angiotensin. I will not go too much into details because there will be several talks today for angiotensin, and I'll leave the authors of these different talks discuss in more detail this. Remember that, again, all patients do not behave the same, and probably when you have indices that the renin-angiotensin system is impaired, like in this trial by looking at the high renin levels, so when you have renin accumulation suggesting that the ACE is not functioning correctly, in this condition, yes, you really have an improvement in outcome, which is perhaps less pronounced in the other group. So probably selected population probably benefit even more of these drugs than others. Again, a plea for the individualization of the selection of the agents that you use at the bedside. What it does beyond increasing MAP? A lot of things, and this was collected in this paper from led by Mathieu Legrand. A lot of things, including also some immune effects. So the impact of immune effect is not the sole aspect of the norepinephrine. It's also observed with vasopressin. It's also observed with angiotensin, and of course, this can be beneficial in some, detrimental in others. At the end, we need to discuss methylene blue. And of course, we are in Belgium, so not only beer, but also the Stroms are also something very special to us. And so methylene blue, where it acts, well, it acts mostly here in the inhibition of the guanylate cyclase, inhibiting the detrimental effect of the excessive nitric oxide stimulation. Well, it seems to be very attractive. Attractive, yes, but not very new, because indeed, with Jean-Charles Prézère, already, yes, a couple of years ago, in the last century, we demonstrated that, yes, methylene blue can be useful in increasing blood pressure and also had some neutral effect on the myocardial performance. What else? Well, at the same time, the group of Kaninche demonstrated that well, it may be not always that good for the heart, because indeed it is somewhat inhibiting nitric oxide, and then in this endotoxic rabbit heart, it was leading to myocardial ischemia. Wow. And so remember, that's not with methylene blue, it's for another nitric oxide inhibitor compound. Yes, there was an increase in the mortality, even though blood pressure was better preserved. So do we have data looking at mortality? We have several trials, and this one is probably the most popular. A new one 2 years ago from Mexico, and indeed, this was very effective in restoring blood pressure, sparing norepinephrine, so everything you wish to see at the bedside. And regarding the other aspect, yes, it was also nice because there was indeed here a significant trend for an improvement in mortality in these patients also. Perhaps one thing which was a little bit strange was the shortening of the ICU. No, that's strange. It was good to see a shorter ICU stay and a shorter hospital stay. But remember that these patients were all ventilated. Half of these patients were under renal replacement therapy. They were receiving already 2 vasopressors, and they received methylene blue on top, and they stay in the ICU for roughly, 6 days and 9 days in the hospital. Oh, 9 days in hospital with ventilated renal replacement therapy, 2 vasopressors. Congratulations. So maybe this may not be applied to your place, where often these patients stay 1 month rather than 6 days for these kind of things. If we look at meta-analysis, yes, the same signal, but of course driven mostly, of course, by this largest trial, and so we need really, really, really more data to know where it's really so good or not at the bedside. And the last candidate is really hydroxycobalamin, high dose of vitamin B12. Well, how does it work? Mostly, unfortunately, perhaps, as an NO scavenger. And I already show you the potential detrimental effect of a scavenging NO. Also, H2S scavenger. And remember that H2S is also considered as a protector for the brain and other organ in cardiac arrest. So is it good to inhibit this? We do not know. At least what we know is that it is effective in increasing blood pressure when other things may not really respond. And so we have very, very few data. This series and another series of this randomized trial of a very few patients, but 10 patients in each group. Of course, no difference in outcome with 10 patients, and just showing that it is effective. But even when discussing effectiveness, can see that, yes, it was effective from T1 to T2, so 2 hours, but then between 2 hours and 3 hours, some patient escaped. So maybe not always as good as we may expect, and so maybe not a long duration of the impact. We really need much more data for this kind of compound. And so at the end, and this will be further developed, of course, today, this afternoon, but a norepinephrine first-line agent, because it's really the most favorable agent globally. Vasopressin derivative, excellent adjunctive, and in some cases, even alternatives to norepinephrine. The exact place is probably to be individualized. It's the same for angiotensin, which is at this stage considered as a third line, but indeed, again, need to be individualized. And whether a mixture of different agents can be better than one agent is probably also something to consider. And at the end, the place of methylene blue and hydroxycobalamin still remains something to be determined, and probably in studies more than in clinical practice. Thank you very much for your attention.
So as we see whether there's any questions out there, people, please raise your hand. Daniel, let me ask you, when do you start a second presser? Understanding this individualized, what dose of norepinephrine would you say I'm going to start a second presser at?
So basically, it's not really the dose, but it's more looking at the adverse effects of the agent or not. I mean, if you see the patient tachycardic, if you see some obstruction, more rapidly will go for vasopressin. derivative. At this stage, the use of angiotensin is still complicated in our country, so it's mostly vasopressin we are discussing here. One of the key aspects is to ensure that the cardiac output is really quite maintained when you decide to switch from one to another one. For the addition, it's somewhere between 0.2, 0.3, 0.5, depending on, again, on the type of patient we face. I know that the Mathieu Komorowski paper and others, Romain Perracchio, paper indeed suggests that you may use it early on. Remember that these are looking afterwards to the data, and this is not prospective data. We need to be very cautious on the potential bias that may occur due to the mindset of the patients, of the doctors taking care of the patients there.
Are there questions? I do have one more question. Are there questions from the audience? Kind of blind up here. See anything? I don't see anything. The methylene blue data that you showed, I'm going to ask this because really I don't see any talks of methylene blue in the next 10 or 15 talks we're going to hear, is very small number of patients, but also pretty provocative. Do you ever reach for methylene blue as a third-line agent, or is it, in your mind, purely experimental still?
For me, it's purely experimental. I'm really too afraid of the nitric oxide experience, where I remember that the phase 2 was almost or even higher number of patients with potentially some beneficial impact even on mortality there. And when they tested it in a large-scale tree, it was totally detrimental. So I think that for methylene blue, we do not know exactly what time, what dose, the way it should be given. In that Mexican trial, they gave it for 4 hours, 2 hours stop. It was a little bit a complicated way to give the drug. Some others used 2 milligrams per kilogram. There it was 1 milligram per kilogram. So we do not know, we do not have enough data, I think, for methylene blue. And I really think that we need many, many more data to ensure effectiveness and safety of the compound.
Thank you very much.
Okay, Jacques, you go to the podium. So the next speaker is Jacques Duranteau from Bicêtre Hospital near Paris, and he will talk about microvascular effects of vasopressors.
Merci Jean-Louis, ça fait longtemps qu'on ne s'est pas vu. So, what about the effect at the level of microcirculation of vasopressor? The first thing is we talk about vasopressor, but I want just to remember that we use vasopressor which are not only vasopressor. For example, if I consider vasopressin, it has also a role at the level of the kidney by reabsorption, and the same for angiotensin II. And it's very important to keep this in mind. When you want to know what is the effect at the level of microcirculation, it could be different between the different vasopressors. So we try all to optimize microcirculation. We do our best to increase the arterial pressure, to give fluid, to have a good balance between fluid and vasopressor. And at the microcirculation, the story is sometimes not the same, because microcirculation needs flow. So you need a tonus, you need a pressure, you need fluid. But during shock, there is so many things. There is alteration of the glycocalyx, there is alteration of the viscosity, there is alteration of red blood cells in hemorrhagic shock. So really, for me, vasopressor help us. But it's not all the solution, it's not all the picture. It's just an help. And I want to show you this. It's during experiments that we perform in our lab. It's in pigs because I think it's more relevant than rats or mouse when we consider hemodynamics. And we perform an hemorrhagic shock, and we test fluid alone for resuscitation, or fluid plus norepinephrine, or fluid plus a higher level of norepinephrine. It was 1.6 microgram per kilo per minute, so a high dose. And the idea was to see if the high dose could be deleterious, and even if the moderate dose after an hemorrhagic shock could be deleterious. And we combine this with fluid resuscitation. You can see that when we only give fluid, we give more fluid than when we give fluid plus norepinephrine. Nothing very smart. And you can see that when you look at the hemoglobin, we dilute more the animal when we give only fluid. And when we have to deal with hemorrhagic shock, we are very concerned about this because we don't want to dilute patient to not decrease the capability of coagulation. So we perform resuscitation in this pig, and we survey the pig during 2 days. So we look at different microcirculations, the sublingual microcirculation, but mainly the kidney microcirculation with contrast-enhanced echography, and we insert PO2, we look at PO2 tension at the level of the kidney, in the cortex, in the medulla, to try to have the more large approach about microcirculation and oxygenation. And this is the macro parameters during resuscitation. You can see that when you look at the cardiac index, for example, even if we give less fluid, the recovery of cardiac index was the same in the three group with less fluid. So Jean-Louis will comment on this. About the DO2, it was the same during the resuscitation. And about oxygenation, the same recovery of oxygen tension in the kidney. And about microcirculation with the contrast-enhanced echography, we observe the same recovery in the three group. So, looking at the histology, and we perform a lot of histology, a lot, because we want to be sure. And we want to be sure of what? We want to be sure that by given less fluid and by given norepinephrine and higher level of norepinephrine, at the end it will be not deleterious for kidney. And this is after 2 days. It's not after the initial resuscitation, it's after 2 days. And you can see that there is no deleterious effect of norepinephrine. So for me, really it's an help. It's an help. So we have to deal with hemorrhagic shock. We have to give fluid. It's hemorrhagic shock. But it helps you to maintain arterial pressure, not to give too much fluid, not to dilute. And at the end, we observe in this model no deleterious effect. I insist because I am sure of the methodology. So another study is the fact that it's in septic animals, and it's another team, and they test the fact that, and I think it's very interesting, they induce by liposaccharide they induce sepsis by increasing dose, and they test an immediate resuscitation with norepinephrine and a delay resuscitation with norepinephrine after fluid expansion. You can see that the recovery of MAP was the same, and you can see that cardiac output was better restored when they add quickly the norepinephrine, and you can see that about the mesenteric flow, they observe at the end of the experiment, they observe a better mesenteric flow when they give norepinephrine in an early way. So at the end, they give less fluid when they start very quickly the norepinephrine than when they delay the introduction of norepinephrine. And what was interesting is that they give also less norepinephrine at the end of the experiment. And if you look at the water in the lung, you can see that when they give fluid with a delay, they give fluid initially, you observe more lung water than when they give immediately norepinephrine. So a kind of saving too much fluid when they give initially the norepinephrine. And about microcirculation, so when you look at the mucosa or the serosa flow, you can see that there is a better recovery and better flow in the mucosa and the serosa when they start to give norepinephrine. And the same at the level of the jejunal villi. You can see that there is a nice recovery, and when you give fluid and after norepinephrine, you have not this recovery in this microcirculation. So what about other vasoconstrictor? So this is in sheep. It's a comparison between norepinephrine and vasopressin. So it's in a septic model, an hyperdynamic model. And what they observe that by a continuous infusion of vasopressin or norepinephrine, you can see that they add, this is a macro result, but at the level of microcirculation, the renal blood flow was maintained with norepinephrine and was better with arginine vasopressin, with a better cortical tissue perfusion, and the medullary tissue perfusion was less altered when they give vasopressin than they give norepinephrine, with a better oxygenation of the medullary when they give arginine vasopressin. But you can see that if I consider renal blood flow, norepinephrine do not so bad. So norepinephrine maintain. Arginine vasopressin do better, but the real plus of arginine vasopressin was at the level of the medullary. And they observe a better creatinine clearance with the arginine vasopressin. So another study, it's a recent study where they perform a cardiac arrest. And what is interesting in this study is that they test a combination of vasopressor. And I think it's very interesting to think this way. So they test for performing resuscitation, they test norepinephrine, and they test a combination of arginine vasopressin and norepinephrine. It's just to open the discussion on this, on the fact that maybe we have to think about a combination of different agents. And you can see that in this study, when I look at the renal blood flow, the recovery of the renal blood flow was better when they add the 2 vasopressors and with a better diuresis than when they only use noradrenaline. It's interesting because it's after cardiac arrest, and you can see that when they give the combination about cardiac blood flow, the carotid blood flow, sorry, and also the cardiac output. The cardiac output was less improved when they add vasopressin, and I think it's important because when we have to deal with an alteration of cardiac function, we have to be cautious about vasopressin, the use of vasopressin. We have to check this. And about the carotid blood flow, they observe a decrease after a recovery, but also there's initially a decrease. So what about angiotensin II? There is no a lot of studies. So they studied a septic model, and they test angiotensin II, and they was not able at the level of kidney to restore blood flow when they test angiotensin II alone or a combination of norepinephrine plus angiotensin II, and they observe less histologic lesion when they use angiotensin II. So we need more study, and we need more animal study and more clinical study to judge the effect of angiotensin II, but I want to show you this study because it's a recent one, and there is not a lot of study, experimental study on angiotensin II. So to conclude, I think its vasopressors are useful to support microcirculation. I show you that we are, in my point of view, too much afraid to be deleterious with vasopressor at the level of microcirculation. And I think that it's important not to work only with vasopressor, but also to think about flow, and vasopressor is just here to help us. And so we have to consider flow and to optimize flow in our patient. So I think it's essential to maintain a good balance between fluid resuscitation and vasopressor dose. And vasopressor can reduce organ dysfunction. There is a clinical study which shows that at the level of the kidney, vasopressor could be interesting. And I think it's interesting to consider combination of vasopressor because, once again, vasopressor is not only a vasopressor, but the 3 vasopressors, so catecholamines, angiotensin II, and vasopressin are really the physiologic response to shock, and we have to think about a combination of the 3 vasopressors. Thanks a lot.
Thank you, Jacques, for this very nice presentation. Questions? Yes, Daniel.
Thank you. One comment and one question. I mean, the first one is for the effect of vasopressin, especially in the hemorrhagic shock. I think it's important to mention that in your model, these animals still receive some volume because we expect, of course, from the natural response to hemorrhage that these animals, as humans, will express a lot of their endogenous vasopressin and will stimulate quite a lot their receptors. So how do you explain the additional effects that you can still have on the volume sparing capacity of angiotensin in this context?
Yes. The first thing is that when we have to deal with shock, and especially with hemorrhagic shock, there is good argument to think that initially we have a good response about vasopressin, for example, but after we have a deficiency of vasopressin if the shock is not stabilized and, for example, the bleeding is still ongoing. So in my point of view, it's why we have to add vasopressin to try to counteract the deficiency of vasopressin. And the other thing is, vasopressin, and it's the same with angiotensin. When you induce an hypervolemia or an hemorrhagic shock, the response is immediate. There is no delay. We have not to wait to have an increase in vasopressin. It's immediate. So for me, it's clearly important because vasopressin, with the reabsorption of water and sodium, participate to the natural response of hemorrhagic shock. And it's why it could be interesting to add to have a combination. The other thing is that, for example, at the level of the kidney, norepinephrine, vasopressin, angiotensin II, they don't act at the same level of the arteriole, and it's why norepinephrine could be, in part, not deleterious, but not as efficient as vasopressin or angiotensin II.
May I ask something else?
Very quick, and a very quick answer, please.
How do we explain the improvement in medullary PO2 with vasopressin? Because some of the vessels come from collaterals coming after the efferent arteriole. So if we constrict the efferent arteriole, we may expect to decrease the flow downstream, meaning perhaps in the medullary. Nevertheless, you reported an increase in PO2 there. How do we explain this?
So, it's, I did not do this study, so it's just the result. And no. Working on microcirculation, I know how microcirculation is complex and how it's well done. It's a wonderful world. It's capable to adapt. No, really. And I have not the response. So it's why I tell this. And it's so complex that when you look at microcirculation, it's so complex that sometimes it's more efficient than what we know about physiology.
We are going to
more smart than us.
We're going to have to leave it there at wonderful world and complex. Thank you very much. And our next speaker from the University of Surrey is Louis Forni, who will speak on postoperative vasopressor usage.
Thank you. I'll spare Jean-Louis my French, so I'll just say thank you. In answer to Jean Daniel's question, the kidney has evolved over millions of years with quite intricate shunting to protect it from its oxygen load. So that's why he saw what he saw, but that's another story. So some of you probably realize that they've let me out of the renal sessions for like a brief interlude. I'm going to talk about postoperative vasopressor use and something called the SQUEEZE study, which you may have been involved in. If you were, thank you very much. It's very preliminary data. There'll be loads of questions which I won't be able to answer, so I'll put that excuse in there. All right, there's my conflicts of interest, none of which interfere with this, and big thanks to Jean-Louis, of course. So I was talking about post-vasopressor use. I had to put AKI in to make me feel at home. And I thought before we start, we'd just talk about some pragmatic aspects of blood pressure control. And this is a sub-study of the POISE-3 randomized trial, which some of you with an anesthetic bent may be aware of, examining the effects of perioperative hypotension avoidance versus a hypertension avoidance strategy. So a kind of normalization of blood pressure and the risks of kidney injury. This was a sub-study of the POISE-3 study, and it just looked at AKI. And interestingly, what it shows that regardless of the approach you took, there was no real effect on acute kidney injury. So although we worry so much about blood pressure and its effects on the kidneys, perhaps we worry a bit too much, or our treatment is a bit overzealous, who knows. So targeted blood pressure didn't really seem to make much difference. And if you look at the lay summary, I always find these particularly interesting, where the authors have to explain it to the general public. What they say is, preventing acute kidney injury during the surgical period continues to be a challenge, right? And that is for sure, probably because we don't altogether understand it. And this is our editorial about the same study. And we said that really, this just stimulates us to revisit the evidence around the associations between blood pressure, kidney perfusion, and ischemic acute kidney injury in clinical settings. And you just heard Jack give a really elegant presentation on such models. So that brings us to this, right? This is the SQUEEZE study. And it's a study looking at the incidence of postoperative vasopressor usage. And this is the protocol, and it was driven by Ben Brown, one of my colleagues, Ibiyama, also a colleague of mine, and some other names you may recognize. It was a prospective international multi-center cohort study. You had to be over 18, you weren't going to have cardiac surgery, and you weren't a day case, right? Otherwise, you tried to include everybody. And there were two cohorts of patients. Right? Cohort A was all patients admitted to participating hospitals for 7 days, right, for surgery. And cohort B was those that actually needed postoperative vasopressor use. Original aim was to collect 40,000 patients. Now, you can't see the date of this on there, but it was kind of late teens, right? And then something happened around 2019, 2020, and it kind of interfered with all our practice. So COVID did get in the way. But despite that, we managed to finish the study, but not with quite so many patients. So some of the definitions I'll use, PVI, right? So that's predominant vasoconstrictor drugs that I'm going to be used. So postoperative vasoconstrictors I'll refer to as PVI. Not repeated doses of IV boluses, beloved by the anaesthetist, to get them off the table into the ITU, right? They had to be on, predominantly on vasopressor infusions. And it excluded vasopressor infusions in the first hour. So if you just had vasopressors for 45 minutes, that didn't count. And those started more than 24 hours after surgery, we didn't count. So we really looked at that post-operative period. And these are the vasopressors we collected evidence on: dopamine, epinephrine, metaraminol, norepi, phenylephrine, vasopressin, and Ang2. So what other definitions we're going to consider here? Well, this we all know, and we've been talking about that a lot in this meeting, in this session, and afterwards, right? But we're also faced with this, commonly, right? We have surgery, and then we have a hypotensive patient, which may or may not have other features. So what do we call that? Postoperative vasoplegia? How do we define that? We don't really know. So this is the physiology underlying these processes very simply, right? So you can have effects with preload, which we all recognize, which you can do something about. There's hypotension during surgery, which could be due to all things, but we can do something about those. But then there's afterload and after effects. And what we have after the operation is we might have relative hypotension, and we consider that restoring blood pressure to this group and perfusing the organs should be a good thing, right? So that must be good. So that's our rationale. So part of the reason for doing this study was to explore the use of post-operative vasopressors and to inform us about further studies we could do to try and unpick this post-operative picture. This is the POCI group, which is a perioperative quality improvement group that published statement papers on post-operative practice. And conflict of interest here. I've been involved on at least a couple of these. Now, this was a practice recommendation for postoperative hypotension. And what it says is really, it's grandma and apple pie, right? It says determine the etiology, yeah, okay. Select the appropriate treatment if indicated, which may include vasopressors. And consensus recommendation from a later group, later paper with Pokey, said recommended that treatment of hypotension be based on the underlying cause, yeah, sure, including vasodilation, etc., etc. But they came out with this statement that the evidence supporting the use of vasopressors to treat postoperative hypotension is limited. And it really is limited. So that led us on to the SQUEEZE study. This had various sponsors, including the European Society of Anesthesia. And our research questions were these, right? How commonly are postoperative vasopressors used and which ones are used? How does that vary between countries and hospitals? What patient surgical and anaesthetic factors are associated with it, and what adverse outcomes, if any, might be associated with postoperative vasopressor use? Because you may think, well, we just support for the blood pressure and it'll be fine. Why bother? Well, if we get a big enough observational database, we may be able to design trials. And hopefully, why we're all here, right, is to improve our patients' outcomes. As I said to you, there were 2 cohorts recruited. Initial one followed a week of data collection. That was cohort A, excluding pregnancy and cardiac surgery. And then cohort B was 30 consecutive patients that needed peripheral postoperative vasopressors. This is a spread of the countries involved. You can see 42 countries, 228 hospitals. We collected nearly 20,000 patients in our first cohort, and then data on a further 6,000 in cohort B. So I think you'd agree that it's a fairly impressive number, given the strains of the world at the time, and we collected data from as far away as Peru and Ukraine. So our Ukrainian colleagues, despite the pressures they're undergoing, managed to also collate some data. So 27,000 patients cohort A and B in total. Now, what I'm going to show you, I hate doing this, right? But it is preliminary data, and so I'd rather you didn't share the results by taking photographs. This is the variation in PVI use between countries. Now, if you're from Scandinavia, don't get upset, right? Because you seem to be using more PVI than other places. But as I'll come to in a minute, we don't really understand that, and there may be very good reasons for that. This is the estimated percentage of PVI using credible intervals. And you can see there's quite a wide interval based on Sweden, whereas if you look down to the UK, which is somewhere there, our credible intervals are much tighter. Well, the reflection is we had far more hospitals from the UK in this study than we did in Sweden, which probably explains that to a degree. But you can see there's quite a good spread of countries there. So what were the factors associated with the use of postoperative vasopressor use? Right, these are pre-surgical factors. So you were more likely to require postoperative vasopressors if your blood pressure was low before you started, which is no great surprise. Also, if you had an infection, if you were bleeding, or if you had a fracture, you were more likely to require postoperative vasopressor. And the severity of surgery also necessitated vasopressor use. You can see that's quite a considerable difference between major surgery and intermediate. And unsurprisingly, urgent surgery also correlated to postoperative vasopressor use, but nowhere near as much as major surgery. ASA status, well, there's no great surprise there either. The higher the ASA status, the more likely you were to receive postoperative vasopressor. And also there were a difference in surgical disciplines. Intrasurgery, well, you could guess the suspects here, right? Increased blood loss, you're more likely to have vasopressor use. If you've neuroaxial blockade, unsurprisingly, then you'll be more likely to have PVI. And vasopressors used during the procedure were also associated with postoperative vasopressor use. So we're using this to maintain our blood pressure and see what happens, right? Here's the variability between centres. This uses something called the median odds ratio, which you can kind of compare groups quite easily with. It changes the logistic regression model to something you can look at. And actually, this shows that there's a difference, right, between two patients in the same characteristics in different centres. So clearly, different hospitals are different, right? We don't all practice the same way, so variability is the key there, and of course, the enemy in terms of patient outcomes. And if we look at countries, again, there was a difference between countries, but not as much as between hospitals, interestingly. So which vasopressors were used and for how long? Well, you can see that, as we've heard from the previous speakers, noradrenaline is the king of the vasopressor, right? So that's the one that is used principally. Dopamine, rarely used. We don't use it, I would say, almost not at all in the UK. But I was surprised. I thought there'd be a bit more of that. But noradrenaline is certainly the key. So let's just have a look at some of the outcome data. Remember I told you this is very basic, very early, right? So if we look at the incidence of myocardial infarction and atrial fibrillation, you can see that if you're on PVI, if you're on postoperative vasopressor use for more than 2 days, about 10% of your patients will have AF. And interestingly, around 4% of the patients suffer myocardial infarction. Similarly, parenteral nutrition, right, unsurprisingly, the gut's not working either through our treatment or what's gone on. And renal replacement therapy also had a staggering increase when our PVI went on for more than 2 days. Right, that's what I'm particularly interested in. And then if you look at the need for ventilation, again, 70% of patients on PVI were ventilated if they're on PVI for more than 2 days. And there was also, obviously, a mortality signal as well as an increase in length of stay. And as Daniel was pointing out, if you're on vasopressors here for more than 2 days, your median length of stay was 18 days. Right? That's ITU stay, not hospital stay, from the studies he was mentioning earlier. Now, it's really important that we don't get confused here between correlation and causation, right? So patients having surgery and anesthesia, end up on PVI, doesn't necessarily mean that's the cause, and receipt doesn't mean it's the cause of the adverse outcome, right? So I'm not saying that, but what I'm saying is there's certainly association, and it's something that needs to be explored. And some of it is really, as I said, quite dramatic. So these are the patient surgical and anesthetic factors, pathophysiological derangements that may lead to this vasoplegia, and certainly if you end up on post-operative vasopressor use, you have adverse outcomes. That's without question, really. Now the mechanisms behind that are complicated, and we really, we can talk about those as we have done, but a lot of it is purely experimental and doesn't really relate to what we're doing at the bedside. But interestingly, we are trying to unpick some of this. So we're doing a study at the moment where we're looking at inflammatory mediators and looking at markers associated with post-operative vasopressor use, including Ang2, and we're looking also at endothelial function in these patients to see if we can get a trigger as to what's causing it. So in conclusion, post-operative hypertension is commonly treated with vasopressors. There's hardly any evidence to guide how we do that. We've shown that there's a significant variability in practice even when you adjust for confounders, and it's associated with adverse outcomes. And studies into pathophysiology will hopefully help us personalised medicine and developing novel treatments. And we need further clinical trials. And I've just put this slide up again in conclusion just to show that if you have a patient when you take over on a Monday morning that had an operation on Friday that's still on post-operative vasopressors, they really are in a bad place, right? And just looking at post-op acute kidney injury, more than 3 days, nearly half your patients have acute kidney injury with the ensuing risks. Okay, so finally I'd like to thank the SQUEEZE study. If any of you took part, thank you very much. That's the steering committee, your national coordinators, and these are 2 of our PhD students, one who's looking at the endothelial cells and the other at renin. And this is Ib and Ben, who are the 2 leaders of the study. I was just there as the grandfather figure, really. With that, I'd like to thank you for your attention. I'm more than happy to answer any questions.
We have time for one short question. Dr. Khanna looks like he's got a question over here.
Thanks. I got 2 or 3 comments wrapped up into one question. Great study, Louis. Just to make this sort of simple, it still looks like if you have a sick patient going into surgery with a long duration of surgery who's going to be hypotensive intraoperatively, even though you separated them out, looks like those are the patients who are going to need postoperative vasopressors, right? But the other part of this is the choice of vasopressor. I saw noradrenaline as the predominant choice. Is that because most of your population came from the EU? You know, there's a big sort of cultural difference here. Phenylephrine still is our go-to intraoperative vasopressor in the US, and still sort of regarded as a vasopressor that I could use with a peripheral IV in the US, whereas, you know, the comfort with using norepinephrine, especially at higher doses on a peripheral IV in the US, is still on, it's better than before, but it's still on the lower side. Is that sort of what you, if you looked at analyzing your population separately, would you see a difference in your choice of vasopressor?
Well, that's one thing we want to do, of course. Yeah, phenylephrine we use a little, but I'm staggered you still use it so much in America, given the publications that showed, you know, when the noradrenaline shortage in the US, everyone switched to phenylephrine and more patients died. That was quite clear. You know, so I'm staggered you still use it. But, you know, it's beloved of our anaesthetists if they haven't put in a central line, right? So they can get away with a peripheral infusion, and then in the ICU we have to, you know, escalate. So yeah, that's one of the streams we're looking at. Yeah, there's an awful lot of data, and it's taken an awful lot of time to unpick. This is just the first straightforward. As I said to you, it's a bit mar and apple pie, right? It appears that the sicker you are, the more vasopressors you'll need, but it's a bit more complicated than that. And it's also, you know, vasopressor choice is going to be very important. So hopefully, it'll inform for future studies.
Just to finish that, atrial fibrillation. Sorry,
like
atrial
30
fibrillation.
Seconds maximum.
Yeah, atrial fibrillation was really high, 10%. 2 days of norepinephrine use, though, right? Yeah. Okay.
Thank you. So we move to the next presentation by Professor Jan Bakker from Netherlands, Rotterdam, but also from Chile now. Talking about, again, norepinephrine versus vasopressin, but not for treating the patient, but for a vasopressor challenge in septic shock.
Thank you very much, Jean-Louis, for the introduction. Yeah, this is the vasopressor test, aiming to increase perfusion pressure in patients that do not improve the markers of tissue hypoperfusion. These are my conflicts of interest, nothing much related to this presentation. Well, as I showed earlier, we think that if we manipulate blood pressure, we will have an increase in organ blood flow, which is at least the reason why we do it. But we have to remember that the relationship between blood pressure and organ blood flow is not a constant one, and is not as forward as we think. Increased perfusion pressure, increased blood flow. That's not always the case. And remember, if you want to increase blood flow, dilating a vessel is way more effective than constricting a vessel. So that's, let's say, the simple basic for this topic. And in addition, it's not every organ that benefits the same from your intervention to increase arterial pressure. We know that the kidney is much more sensitive to changes in blood pressure than, for instance, the gut or even the heart. And ultimately, we want to improve organ blood flow, but we have very limited parameters of adequacy of blood flow or blood delivery to individual organs. So we're in clinical practice extremely limited. We know that if you have abnormal peripheral perfusion, in this case, the study we did in Austria, we used capillary refill time. So if you're vasoconstricted, you have decreased perfusion of your vital intra-abdominal organs. So in the study, we showed that if you have longer capillary refill time on the x-axis, then the resistance index, and that's the inverse of flow. So the higher the resistance index, the lower the flow. The higher your capillary refill time, the lower the flow in your liver, kidneys, intestine, and spleen. So there is a relationship, and that's why in the Andromeda 1 and Andromeda 2, we aim to normalize capillary refill time, because I think no one in the room would want something like this. We know that if you use norepinephrine, and in all our studies, we basically only use norepinephrine, so Andromeda and 1 and 2, and also in the lactate study, we only use norepinephrine, and that's basically based on this study from Alpha. What she showed is if you increase the blood pressure with increasing norepinephrine, you can have a very significant increase in blood pressure, 54 to 70 to 76. And especially, you do not have a decrease in cardiac output. Not in everyone. Remember, there are these patients that still decrease their blood flow, their cardiac output, but in general, you have an increase. So seems to be a relatively safe drug. If you have abnormal microcirculation, then increasing the perfusion pressure is probably, let's say, the right way to go. Don't do this in patients that do not have an abnormality. That doesn't make any sense. So correct the microcirculation in those in whom it's abnormal, and then an increase in blood pressure could be a way to effectively do this. That's what we did in the Andromeda 1 study, where we compared chasing lactate levels. So optimized treatment to have a decrease in lactate levels of 20% every 2 hours, or normalize your capillary refill time. And you use fluids, and if fluids didn't work, then in the hypertensive patients, we would do a vasopressor test. So we would increase blood pressure to 80, 85 by increasing norepinephrine. And if you were not hypertensive, we would do an inodilator test, so try to dilate the vessels with the use of dobutamine. And this is what we found. This is the vasopressor test. So increasing mean arterial pressure with increasing the dose of norepinephrine. The data are not great because in the case record form, we did not exactly monitor the vasopressor test. Much better in Andromeda 2, but in Andromeda 1, we just asked the centers, did you do it, and give us the data. Overall, there was an effect of increasing blood pressure and improving capillary refill time. This is, of course, the bad ones. They increase their capillary refill time, which is probably not what you want if you add a vasoactive agent and increase blood pressure. Interestingly, in the patients where they decreased norepinephrine, there was, except for 2, an improvement in capillary refill time. So in this one, nothing happened. The blood pressure went from 111 to 91. That's still a lot of blood pressure, to be honest. But no change. But in this patient, they decreased the norepinephrine and the capillary refill time worsened. In all the others, it improved. And so optimal mean arterial pressure, if you're, let's say, chasing capillary refill time, doesn't tell you it needs to be 65 or more than 65 or less than 65. You have to find out. And that's why we, of course, did these vasopressor tests. Now, the next question is, given the study from Alpha Hamzoui in Paris, should we only do vasopressor tests with norepinephrine because it seems to be much more safe than another vasopressor? And we use vasopressin in addition to norepinephrine, to be honest, not as a single vasopressor, in many of our septic shock patients. And so we set out to do a study where we compared a vasopressor test with either increasing norepinephrine or adding norepinephrine or adding vasopressin to a baseline norepinephrine. And so this is the norepinephrine group, this is the vasopressin group, as you can see, very comparable at baseline. So how much norepinephrine did we need to increase the mean arterial pressure from around 60, 70 to the 85, 80 to 85? That's in this slide. So we had to increase the norepinephrine from 0.18 to 0.28. That's a significant increase in norepinephrine. And if you look at the mean arterial pressure from around 66, so that's what we aim for, to the endpoint of 85 as a result of the change in norepinephrine. And by adding vasopressin, we basically did not change the norepinephrine. So not a huge effect that we could substitute, but we had a significant increase with the addition of vasopressin in these patients to the ultimate goal of 80-85. Now, if you look at the changes in the macrocirculation, you can see that norepinephrine did not much on heart rate. There's a lot of discussion that norepinephrine induces tachycardia. It can. I mean, I've seen it maybe a few times in my lifetime. But this is not like you start norepinephrine and, oh, yeah, so by definition, you will have an increase in heart rate. Of course, this might be related. If you have a very severe increase in afterload, you get a reflex decrease in heart rate with counteracts. But if you look at the data, there are not a lot of patients that increase their heart rate. This one a little bit, this one a little bit, but no statistical significant difference. On the contrary, if you give vasopressin, the heart rate decreases. Not in everyone, a small increase here, but I mean, this is a significant decreases. So much more of a signal that if you add vasopressin to increase the blood pressure, you will decrease heart rate. In the stroke volume, so flow, remember you're aiming for perfusion pressure, but you don't want to reduce flow. There was a signal that with norepinephrine, indeed, you had a somewhat increase in stroke volume. Not huge, but it was a significant and stable increase, with only one patient having a deterioration, but it was already high. This is, of course, somewhat more troublesome, not that great, and decreasing a little bit. In the vasopressin group, there was nothing. So if you're interested, basically, in perfusion pressure, vasopressin is great. If you also want some blood flow increase, then vasopressin is not that good. If you look at cardiac output, overall, in the norepinephrine group, there was a small increase in cardiac output, 5.5, 5.8, again, nothing to be very glorious about. But with vasopressin, there was no change. What about the capillary refill time? But because ultimately, we do these tests in Andromeda 1, we did in Andromeda 1, do in Andromeda 2 to improve capillary refill time. If you look at the overall effect, there was an improvement with the vasopressor, any vasopressor. But if you look at norepinephrine and vasopressin, and you compare the two, only vasopressin improved capillary refill time. Again, the problem is a little bit that there were many patients that already had a normal capillary refill time, and so in these cases, the vasopressor test was done because of lactate levels, Andromeda 1. But as you can see, in some of these patients, there is a significant decrease in capillary refill time when you increase perfusion pressure with vasopressin, whereas in some cases with norepinephrine, there is a significant worsening of capillary refill time. So very much a mixed bag of signals, to be honest. We looked at patients that responded with an increase in stroke volume, probably related to some inotropy in norepinephrine, and maybe in both cases an increase in venous return. If you look at the effect in the responders, so the patient that increased their stroke volume, capillary refill time decreased significantly. If you have a non-responders, it did not decrease. So if you have an increase, basically, that's the message. If you have an increase in perfusion pressure with an increase accompanied by an increase in stroke volume, that works. Cardiac output was not relevant in any of the groups. It didn't change cardiac output, but it changed stroke volume. If you look at regional circulation, we did this with the resistance index, as I said in the beginning. 2 hours surprise, nothing. So nor the increase with vasopressin, nor the increase with the norepinephrine, nor the normalization of capillary refill time or the improvement in capillary refill time was associated with any significant change in either the kidney, the liver, or the spleen. And so this was a well-resuscitated group already, so it's not your baseline group that you are actively resuscitated. They were all already resuscitated before, but in general, no effect on regional circulation. So, in conclusion, abnormal capillary refill time is related to increased morbidity, mortality, and vital organ perfusion, the study we did in Austria. The vasopressor test aims to increase perfusion pressure. There is not much evidence that increasing mean arterial pressure in general has a significant effect on outcome. In Andromeda 1, increases in mean arterial pressure by increasing norepinephrine were associated with improving capillary refill time and lactate levels, but not normalization. And lactate is, let's say, has a much longer time constant than capillary refill time, so you could argue lactate, it's too fast, but capillary refill time should respond immediately. In this study that we did, norepinephrine is associated with improved flow. Improved flow is associated with improved capillary refill time, and improved perfusion pressure with vasopressin is associated with improved capillary refill time. However, the vasopressor test is an ultimate example of individualized care. I think in the vasopressor test, inodilator test, whatever test you use to stress the circulation to come to your ultimate endpoint is an N is 1 experiment. So average results from studies like this should not be used as a target recommendation in guidelines. Thank you very much.
Thank you very much, and also for this provocative conclusion. Questions? So you alluded to the study by Olfa Hamzaoui about the effects of norepinephrine on cardiac output. Just to remind people that blood pressure initially was very low because it was at the early stage of resuscitation. In your study, blood pressure was already around 65 when you perform the vasopressor test. So maybe the results can be different in terms of perfusion, flow, maybe CRT. We did not measure CRT in the first study 10 years ago, but maybe it could be different. So the vasopressor test is a test when you want to know if it is helpful or not to increase blood pressure above 65, but initially maybe improving blood pressure, improving MAP from 49 or 50 to 65 maybe may result in a good perfusion of tissues. This is what I wanted to say.
Yeah, that's something we don't know from this study. But the reason to do the vasopressor test in all of these patients was there was no adequate change in markers that we use for perfusion. And so in patients with capillary refill time where they did the vasopressor test, it was because lactate did not come down. And in patients with abnormal capillary refill time, it was to improve the capillary refill time. So basically, it's the Andromeda 1 objective, where you either target lactate or you target capillary refill time. And these are all already fluid unresponsive patients without adequate response to this, let's say, initial fluid resuscitation. So clearly different from the patient from alpha, yeah.
Yes, microphone, please.
And again, we're sort of a little bit behind time, so quick question, quick answer, please.
Okay, I liked your first slide because I think that showed also an autoregulation mechanism. Is that not the key, let's say, to also understanding a little bit of these data, that we have to know what is the lower limit, and maybe if they are below the lower limit, then we know whether we should increase our vasopressors?
That's a perfect question, and of course, that's the $100,000 question, because we don't know. In some patients, and we used hypertensive patients to do the vasopressor test, because that's, let's say, the evidence we have from both Andromeda 1 and the Pierre Asfar study, but we don't know. I mean, we have patients where you increase blood pressure and you get increases in blood flow over a large trajectory, and not every organ is like the brain. So we don't know. Would be great to find out, but we don't know.
Thank you very much. We're now going to move on to something of a mini symposium on renin and angiotensin, because the next 5 talks are on this topic. And our first speaker has come all the way to us from Brussels, is Filippo Annoni. My apologies if I pronounced your name incorrectly. Blame the American. Speaking on the importance of the renin-angiotensin system.
So thank you very much. Good afternoon, everyone. Those are my conflict of interest related to vasopressor and RAS. The renin-angiotensin aldosterone system, if we want to use the full name, at least used to be a pretty simple, straightforward system, okay? Like a linear cascade of biochemical reaction. We start angiotensinogen, pass through our renin to angiotensin 1, and then angiotensin converting enzymes, we all know that, essentially with one effector, angiotensin 2, acting on 2 different receptors, 81 mediating vasoconstriction, aldosterone release on the inflammatory response, and 82 basically doing the opposite job. So the first question that we should ask ourselves is this an important system for humans, a regulatory system? Well, there, what you see is the evolutionary journey of the exon of angiotensinogen. It's the red arrow, over 500 billion years. And essentially, if you have the time to go through this interesting article, you would see that we essentially have the same angiotensinogen protein than a chicken or a lizard, if you wish. To my eyes, that happens only when we are dealing with a very important system and a very efficient one. So no big changes are retained throughout the evolutionary process. But unfortunately, when we face such an important regulatory systems, the things get a little bit more complicated. So this almost incomprehensible slide there serves just to show you the galaxy of the RAS, how many characters populates it right now. So right now, since the last 25 years, parallel or alternative or non-canonical, call it as you want, part of the system has been described, which is based on the action of new converting enzymes, type 2, one peptide, mainly angiotensin 1 to 7, acting on a specific receptor mass. Now, if we put things a little bit more in a proper way, let's say, let's not dig into the details, it's not the purpose of these presentations, but look at the effects that these receptors all over mediate in both sense within the RAS, well, you see that this system essentially regulates vascular tone, fluids, inflammation, and then there are several other effects, organ-based, such as memory. 84 is basically in the brain. So those things are important for the critically ill patients, are the things you would like to control, actually. We cannot, but we wish to control those things. So it is an important mechanism, It's an important system. It is important also for us. Now, most of the literature tend to depict it as this. There is one good system there, and there is a dark classical RAS. We should block it. And we should block it when it's constitutively upregulated. We know that's arterial hypertension, that's myocardial infarction. But we are dealing with something else. So we should look at the system as a whole, like we should look at this masterpiece as a whole. And so we should consider RAS as a complex, rather useful system in its entirety. If it's important for us, how does the system respond to the pathologies that we deal with? Well, at least for sepsis and septic shocks, we will see shortly after, there is evidence that suggests that the system is profoundly dysregulated. At least there are evidence suggesting we can find and see an increase in angiotensin I to angiotensin II ratio, which essentially means decreasing ACE activity, decreasing conversion. There is evidence that we can see high renin levels, so-called hyperreninemic hypoaldosteronism. But if we deal with the septic shock, more evidence accumulates. There are two other mechanisms that can be seen, at least. One regarding the receptors. 81 receptors are internalized and less frequently synthesized. So there is less 81 receptor for angiotensin II. And there are a whole bunch of non-specific peptidases circulating, the most famous being dipeptidyl peptidase 3, DPP3, that tends to destroy the circulating angiotensin II. So I was actually skeptical, not on the evidence that's quite solid, but on the idea that such a system that is made to respond to something was so much profoundly dysregulated. Well, we carried out a small study ourselves too, with Camille from Lille, when she was doing a fellowship period with us. We investigated this in 20 septic shock patients. Let's call them clean, in the sense that they had no prior exposure to RAS-altering drugs. And we followed them, and we compared with 30 healthy controls. Here you see the 6-hour time point after the shock onset. So we can confirm everything that has been seen. We can add that ACE2 activity was increased. So I would say we have less angiotensin II, less receptor for angiotensin II, a little bit more of a push towards the alternative RAS. We could not say till when this is the normal answer of the organism, but it's clear that when we are dealing with septic shock, a response that deprives the organism of an endogenous vasopressor seems at least inappropriate. Now, if there is such a thing, the first things we can imagine is what we can replenish an insufficient system. This is kind of in fashion, but it's modern, but it's definitely not new. It has at least 70 years. We know angiotensin II is a strong vasopressor, but we had to wait until recently, and I will not go into details because the next 4 talk deals with it too. We had to wait until recently to see first a commercially pharmaceutical grade of the compound to see that it's not only effective in raising blood pressure, but maybe safe and in most shock types. So we can give angiotensin II. That's the easy answer we will talk about later. We could imagine to decrease the effective action of those peptidases. We know that DPP3 is increased in patients with cardiogenic shock, especially when it's refractory, and that this data has been confirmed in other series with multiple cardiogenic shock etiologies. But so far, as of today, there's only small animal studies that have been carried out with specific antibodies to block the action of these molecules. Although promising, because what we could see is the rise in endogenous angiotensin II, well, let's say this is very preliminary data. Another thing, this is a little bit counterintuitive, if you wish, is that we could use those compounds to re-establish a functional classical renin-angiotensin system in situation of prolonged blockade. Here you see the results of the administration of a small interfering RNA molecule, zilebesiran, which is a new antihypertensive drug. And you can see that it's effectively capable of reducing, after a single injection, systolic blood pressure 6 months after the administration. So the authors that have been challenged of these two studies, actually, that have been challenged, came up with a solution that is an antidote, which acts the same way. It inactivates the first medication, which basically inhibits the synthesis of angiotensinogen. It's called Reversir. And this is an interesting thing, but takes 5 days to reestablish the blood pressure. So maybe in future we will be challenged with situations in which, well, we have to act quickly, as in septic shock, and we have a totally iatrogenic dysfunction of the renin-angiotensin system. Last but not least, the alternative RAS. You can find almost everywhere that is associated with vasodilation. Yet there is not a single antihypertensive drug that is based on the system. And this is because probably vasodilation here counteracts angiotensin II vasoconstriction. So it doesn't work really well as a vasodilating agent. Why do I talk about it, and why do I talk about it in a session on vasopressors? Give me 2 slides and I'm there. The first one is a classic thing. We know that if we block in hyperinflammatory state here, it's RATS and it's an LPS model of ARDS. If we block the renin-angiotensin system, the AT1, we can decrease inflammation. Or we could imagine to do the same by giving angiotensin 1 to 7, which has been given during COVID-19, at least in 2 randomized trials to humans, without real effects on mean arterial pressure. But actually, we could think, and this is what we did with Bruno in our experimental lab, that maybe there is a place if we can equip these, in this case, animals, sheep, it's a clinically relevant model of fecal peritonitis. They received concurrent treatment with angiotensin 1 to 7, and they did not develop shock, basically. So we could maybe decrease the quantity of vasopressors. But be aware, I'm not suggesting that angiotensin 1 to 7 serve to do this. I have no idea when should be done and who should be done, but there may be a place to be investigated because it seems that the balance of the entire system were off. And there, the animals clearly showed less inflammations, better renal function. Now, there was also a plethora of potential actions that we could be interested in this system, so it worth maybe investigating deeper. This is the last thing that I'm saying, and this is actually from last year. So I'm refurbishing this slide on which I'm still working on, so quite slowly but advancing. The idea behind is that maybe these data that are accumulating one day will lead us to the possibility to use the RAS as a primary tool to address actual vasodilatory disturbance in our patients. And with this, I think that we can move to my conclusions. So during acute illness, I think we can all agree that RAS nowadays is profoundly disturbed. RAS modulation could represent an important opportunity for the critical care physicians. The classical RAS enhancement is already a reality at bedside in most countries. But maybe in the future we will see different applications, different molecules acting on the same system, or why not different researches acting even on the alternative RAS. With this, I thank you very much for your attention, and I invite you again to our first edition of the International Symposium on Intensive Cardiovascular Care the next September. Thank you very much.
We have time for a couple of questions, if there are any. Looks like Dr. Khanna has one. As we're moving the microphone over to Dr. Khanna over here, let me take the moderator's prerogative and ask you, and I know this is an unfair question because you already said you didn't know the answer, but can you speculate when you might want to target the alternate RAS system?
Wow, yes, but indeed, I don't know the answer because there are out several compounds that you can imagine to use, at least for research purposes today. They seem all similar, yet they do act in kind of different ways. Especially the formulation, different formulations of angiotensin 1 to 7. It seems that they bound differently to the MAS receptor. or they have a conversion rate that is different to other molecules such as lamantine. So I would like to see a mast receptor agonist, but I believe angiotensin 1 to 7 is acting differently than synthetic mast receptor agonists. So I would like to see angiotensin 1 to 7 tested on a larger scale.
Thank you. Ashish?
Thank you, Filippo. I'm glad to see your last slide that you're still working on resuscitation. The issue of septic shock and why Ang2 is unavailable to act or is low is rather complicated, and I'd obviously like to add or include your comments on whether there is some sort of circulating inhibitor to endogenous Ang2 that we still don't know exists, probably exists, right? And also your comments on angiotensinogen. You know, there is some interesting data around low angiotensinogen driving the low Ang2 downstream.
I have to be short because in 12 minutes this is a very complex system. You know better than many of us. The two things there are more circulating peptides. I talked about DPP3, but polypeptidase seems neprilysin does not seem to act the same way, although it seems logical. TAP, there are so many that I cannot even think that there is no more to be discovered in that side, so probably there is much work to do. Angiotensinogen is the starting break. So now, whenever we see something that deals profoundly with it, I think there is a lot still to do. On my mind, but I will make it through it one day, investigating situations in which angiotensinogen synthesis is reduced, standing acute and chronic liver failure, might be a perfect model to see how the RAS will respond to exogenous medications. So we'll see in the future, I hope.
Thank you very much, and thank you both to the speakers and the audience. We're exactly halfway through, and we're on time to the minute, so thank you, everybody.
So we move to the next presentation by Dr. Emily C. We'll talk about renin, maybe the best biomarker we'll see.
Fantastic. So these are my disclosures. So biomarkers are a core component of contemporary ICU practice, where we're responsible for caring for multiple patients with complex clinical syndromes. They enable us to group and to classify patients in order to support an individualized approach to critical care. Outside of the clinical space, they also provide important insight into the pathophysiology of some of these syndromes in order to enhance therapeutic discovery and identify potential drug targets. So biomarkers, as we use them in the clinical setting, can broadly be classified into three types. So we've got diagnostic biomarkers that enable us to confirm diagnoses. We've got prognostic biomarkers that help us predict the clinical outcomes and the prognosis for our patients. And then we've also got predictive biomarkers that enable us to predict a treatment response in an individual patient. And I'm going to be talking about renin in this context during this presentation. So renin, as we've heard a lot about renin in the previous talk, it's been the subject of circulatory research for some time, but more recently it's been proposed as a candidate biomarker for multiple of these complex syndromes, but especially sepsis and shock. So we're very well aware, and we've just heard, that dysfunction of the renin-angiotensin-aldosterone system is very common in critically ill patients. And both from human and also from animal studies, we can see evidence of decreased expression of the angiotensin type 1 receptor. We've got decrease in the angiotensin converting enzyme level and activity, and other manifestations of impaired or dysfunctional RAS and angiotensin II signaling. So in both health and disease, the renin-angiotensin-aldosterone system plays a central role in maintaining blood pressure, glomerular filtration rate, and electrolyte balance. And renin, as the initiating component of that system, is a proteolytic enzyme released from the juxtamedullary cells of the kidneys in response to several physiological stimuli. In the ICU, commonly in response to hypotension, but also in response to sympathetic nerve activation, low circulating angiotensin II, reduced sodium delivery to the distal tubule, and importantly, its release is inhibited by increased angiotensin II levels. So renin's responsible for cleaving angiotensinogen to enable the angiotensin converting enzyme to convert angiotensin I into angiotensin II, which then allows the end organ actions of this molecule, which are particularly relevant for our patients. So when we think about renin as a potential biomarker, there are several important considerations. So firstly, in terms of how it's interpreted, so importantly, it's got a short half-life, so it's something that is a dynamic marker and that can be measured serially, much like, in the same way that we measure lactate, and we'll be talking about the renin-lactate comparison during this talk. But its production is affected by several commonly used medications. We're all aware of the RAS inhibitors, but also beta blockers and other drugs that many of our comorbid patients who come to the ICU are receiving can impact at least the admission renin levels. It's measured via a very standard assay that's available at most hospitals, where it's regularly sent off for screens of patients with secondary hypertension, and all the assays are approved by regulatory bodies and established. But it's not point of care, and at many centres, certainly at mine, it's batched, meaning that there's a several-day delay to the results, so it's not currently able to be used in that predictive capacity. There's also several potential pitfalls to how we might use it in the intensive care, where there's recognised to be diurnal variation in healthy subjects. Also, its molecular weight is at the threshold of molecules removed by renal replacement therapy, which would make it difficult to interpret. And finally, the reference ranges that the lab produce are established in healthy subjects rather than critically ill patients. And we don't actually know what the normal renin level is in a critically ill patient beyond the results that we get from trials and observational studies. So to address some of these pitfalls, Gleason and colleagues performed a really important prospective observational study at a single centre looking at a mixed ICU, and they included adult patients with a baseline GFR of at least 30, and they measured the plasma renin 6-hourly, and they also, for patients on CRRT, measured the extracorporeal CRRT concentrations as well to look at clearance. They had 112 measurements from 20 patients. And essentially they found that unlike in healthy controls, there was really no significant diurnal variation in renin levels across the 4 time points that they measured, albeit small population of patients. Moreover, even though CRRT did remove some of the renin, it was actually negligible. It was about 4%, and it was directly proportional to the blood flow rate. They also weren't able to identify any difference in renin level between types of AKI. So more recently, there's a scoping review that's been published which has performed a fantastic summary of the renin biomarker literature, and the highlights of which I'm going to present now. So this group included studies published in PubMed until 2023, which were looking at serum renin levels and their association with clinical outcomes. The primary outcome was mortality, and there were also renal outcomes like acute kidney injury, renal replacement therapy, and outcomes relating to angiotensin II administration. In total, there were 16 eligible studies, predominantly in sepsis, some in cardiac surgery and mixed critical illness cohorts, and then across shock, burns, out-of-hospital arrest, and liver surgery. Most were observational studies, prospective observational studies. There were some secondary and post-hoc analyses of clinical trial cohorts. Almost all studies measured renin concentration rather than renin activity. There were just 2 studies that reported renin activity. And there was very substantial variability in the renin levels that were measured. So from 7 to more than 3,000 picograms per mil, with a differential between survivors and non-survivors, with non-survivors tending to have higher renin levels. If we look at that in more detail, many of these studies were able to identify an association between high renin level and increased risk of mortality, both in hospital and at 28 days. They were also able to find an association between high renin level and acute kidney injury, requirement for renal replacement therapy, and major adverse kidney events. And finally, an association between high renin level and vasopressor requirements. 2 studies looked at dynamic changes in renin and found that renin trajectory was associated with hospital mortality. So I mentioned that there's been some work comparing renin with our favourite shock biomarker, lactate, in terms of the comparative performance. And this is the initial study I presented earlier by Gleason of 20 patients looking at ICU mortality. And the AUC for renin at a cutoff at 40 was 0.80 compared to lactate of 0.70. So it certainly didn't perform inferiorly. Similarly, Jayaraju et al. Studied 53 patients looking at, within the ICU looking at hospital mortality and found the slope of the natural log of renin was independently associated with hospital mortality with an adjusted odds ratio more than 10, whereas the slope of lactate was not significantly associated. So again, it seems to, in these 2 small studies, there's evidence that it's something that could be used as an alternative marker of tissue perfusion. So that was looking at renin as a prognostic biomarker. What about as a predictive biomarker? Well, in this secondary analysis of the ATHOS-3 trial, patients with catecholamine refractory vasodilatory shock were randomised to receive either angiotensin II or placebo. In this secondary analysis, patients were stratified according to renin level, and it was dichotomized at the median. So the median renin was about 172 picomole per mil. And so this is the low renin group. So it's hypothesized that if you've got a low renin, your RAS is likely intact, whereas if you've got a high renin, that makes it more likely that you've got some RAS dysfunction with dysregulated angiotensin II signaling. And so in patients with low renin, there was no survival benefit to receiving angiotensin II versus placebo in comparison to patients with a high renin in whom we suspect there may be an element of RAS dysfunction who had a clear survival benefit with receiving angiotensin II, hazard ratio of 0.56. So that's mortality, but what about other relevant patient-centred outcomes in the ICU? Well, again, patients who had a high renin, who received angiotensin II, were more likely than those who received placebo to successfully liberate from renal replacement therapy by day 7 in an alive state, as opposed to patients with a low renin for whom there was no benefit in terms of their organ function. So it seems that renin, as well as identifying patients at higher risk of mortality and end organ dysfunction, may actually also be able to guide therapy in terms of vasopressor selection, and conversely, identify patients who may not benefit from angiotensin II. So following on from that, in Melbourne, we've performed the Aramis study 3 years ago, which is published, and we've also looked at, within that, at renin levels within our cohort. So Aramis was a single-centre prospective observational study of angiotensin II as the first-line vasopressor, and we gave that to 40 patients who were matched, propensity score matched to 80 noradrenaline controls, and we identified that baseline renin identified patients most likely to survive if they had angiotensin II, and also a failure of the renin level to fall over 24 hours identified non-responders. So not only may renin eventually, once all of this is validated and better understood, be able to identify patients who are likely to respond, at 24 hours or at other defined time points, it may also identify non-responders in whom this drug can be stopped. Pleasingly, there's multiple ongoing studies looking at renin in various capacities. Some are looking at it prognostically, some are looking at renin kinetics, and some are looking at it in terms of responsiveness to angiotensin II infusions in cardiac surgery. So bringing that all together, biomarkers are a core component of how we care for patients in the intensive care, both from a diagnostic perspective, but also from a prognostic and therapeutic perspective. Renin has been proposed as a potential candidate biomarker for several of the complex intensive care syndromes that we manage, including sepsis and also shock. And there may be other patient populations for whom renin can help improve patient care. From several observational studies and also secondary analyses of clinical trial cohorts, a high renin level has been associated with mortality in hospital, in ICU, and at 28 days. And it's also associated with end organ dysfunction, including acute kidney injury, renal replacement therapy, and major adverse kidney events. Some studies have suggested that renin may even outperform lactate, although these are small and would require validation in larger populations. Eventually, given we've got a therapeutic option for the renin-angiotensin system with angiotensin II, renin may be able to guide patient selection in terms of initiating angiotensin II, but also stopping angiotensin II in non-responders. And the hope is that we will be able to access renin more readily in the clinical setting through point-of-care testing devices to enable us to make these therapeutic decisions in real time rather than retrospectively from batch samples. And the timeliness of the result is really going to be the determinant of how feasible it is to use renin moving forward as a preferred biomarker. Thank you.
Thank you very much for this very clear presentation about renin. Questions? Yes, Ashish, again. Microphone, please. Thank you.
Probably there's a ceiling limit on how many questions I can ask, but sorry, can't help myself ask this question. Emily, great presentation. I'm going to ask you a question that people have asked me when I've tried to present the same data. Is renin going to replace lactate? And based on what you answer, I'm going to ask you whether renin can ultimately be used as a screening test as well. Lactate is a screening measure.
So,
please.
Yeah, that's it. I think the first point of that question is really important because I think we're not saying that all critically ill patients have RAS dysfunction as a contributor to their organ failure or organ hypoperfusion, but certainly a high renin level may, in terms of a positive predictive capacity, identify patients for whom that's a relevant pathway. Much like in some patients who are profoundly shocked, they'll have a normal lactate and it just doesn't make sense. So it depends which pathway you're trying to monitor. So I don't think it will ever fully replace it, but whether it could be used alongside it as sort of gathering more information to better understand the circulatory state, given it's so challenging for us at the bedside to accurately assess the circulation in terms of organ perfusion.
Thank you. I have two questions, short questions. Do you use renin in clinical practice right now?
So we don't use it in clinical practice outside of our trial, really for the purpose that it's delayed.
Now, just imagine a situation. A patient with shock refractory to norepinephrine escalation plus vasopressin. Can renin concentration be normal at that time or always high?
So we certainly had patients in our Aramis cohort who at baseline had a normal renin and who over 24 hours had an increase. And so the different patterns and trajectories, I guess, of renin kinetics each have different prognostic implications. So I think we've only really got two relatively small studies looking at renin kinetics. So since that scoping review, there has been a secondary analysis of the Victus trial, which gave extra information as well about the kinetics. But it's something that we need given the heterogeneity of the population, we need much more information about how to interpret these. A lot of patients are on RAS inhibitors, they're in the system for different lengths of time, when did they have their last dose, etc. So there's so much heterogeneity that having large databases to sort of help us understand how to interpret it and what's normal will be key.
Yeah.
I'm hoping Ashish is building one of those.
Okay, thank you very much for your presentation. Thank you.
And before I introduce the next speaker, every single person in the audience may ask Ashish questions when he talks last. Some people can ask 2 or 3 if they like. Our next speaker assuredly needs no introduction, but I will introduce Rinaldo Bellomo from Australia.
Thank you very much. I'm going to focus on vital organs and the effect of angiotensin II on them. So you're familiar with the canonical understanding of the system, that angiotensin II is a pervasive hormone that affects the sympathetic system, it affects the way the kidney works, it affects the circulation, and it triggers vasopressin release by the pituitary gland, amongst many other things. And I want to take you back to the world that I knew 17 years ago when I started doing work around, I know, it shows my age, when I started doing work around angiotensin II in the sheep lab in Melbourne. We knew that RAS was a major contributing factor to the development of hypertension and cardiovascular disease. We knew that inhibiting it was a really important thing, and it had been one of the greatest success stories in medicine, and blockade of the receptor came a close second. We all knew that angiotensin II was bad. You really didn't give it to people. That was the world that I knew in 2008 when we started studying septic acute kidney injury. And when you develop a model in the animal lab, in the sheep lab, and you administer continuous infusion of gram-negative bacteria, what you see is that unlike people's expectations, renal blood flow actually goes up. Renal blood flow goes up as the kidney fails. And you can see that the creatinine goes from 100 to 300, while the blood flow goes from 200 in the sheep to 600 per kidney, and the urinary output plummets. So you have this unique situation where during septic shock simulated by gram-negative bacteria, you have hyperemic renal failure. And then if you think about that, so how can this happen? How can you have increased renal blood flow and you lose GFR? Well, one of the logical explanations for it is that you must have lost intraglomerular pressure. So to lose intraglomerular pressure with hyperemia, it must mean that the afferent arteriole has dilated and that the efferent arteriole has dilated even more. So that there is increased flow but decreased pressure. The glomerulus is a pressure system and it cannot filter. Then if this is true, the obvious next step is that you need to give an efferent arteriole a vasoconstrictive agent. And that is the way we reasoned. And on that reasoning, we did an experimental study by giving angiotensin II to these animals with acute kidney injury secondary to gram-negative bacteremia in the hyperemic model of acute kidney injury. And when we did that, as you would expect, when we gave angiotensin II compared to placebo, there was a significant decrease in renal blood flow. This is physiology 101. Fantastic. There was a decrease in conductance, which is the inverse of resistance, so you got renal vascular vasoconstriction. Fantastic. Physiology 101. And then there was massive polyuria, and then there was a massive increase in creatinine clearance. So this data supported the view that there must be efferent arterial vasoconstriction, and if you actually decrease the blood flow back to normal with an efferent vasoconstriction like angiotensin II, you achieve the goal of improving GFR. Very nice. Is this just in the sheep? Dan Leisman's got very nice work in the mouse in a model of sepsis, which is cecal ligation puncture. Using ultrasonography, he was able to demonstrate several things. First of all, that there is a model similar to ours, as I will show you in a minute, but also that there was a change in the receptor, not only in potentially the ability of angiotensin II to be generated, but also the receptor, which is less expressed, suggesting that there is a modulation of the ability to achieve vasoconstriction in this model. And then it was able to show that the urinary output was increased by the administration of angiotensin II, that the BUN was improved by the administration of angiotensin II, that the renal blood flow was elevated in this model and was decreased by the administration of angiotensin II, and the creatinine increase was aborted by the administration of angiotensin II. So this is another model showing exactly the same thing. Do we have a human model to show this? Well, the human model that we have is the ATHOS trial, and this is the patients that had acute kidney injury with treatment by renal replacement therapy, and this is a post-hoc analysis of these patients that were randomized to receive angiotensin II or placebo. And in this human model of vasodilatory shock, the administration of angiotensin II did two things. First of all, improved survival, and secondly, it improved the speed at which and the rate at which the patients were able to come off renal replacement therapy. So we've got a sheep model, we've got a mouse model, and we've got a human model that the administration of angiotensin II has beneficial effects on kidney function. We've extended the work on the patient with acute kidney injury, looking not only at the patient that received renal replacement therapy, but looking at different stages in the ATHOS trial. And now you can see the effect on survival in the human model, looking at those with renal replacement therapy, as well as those with stage 3 AKI. These are the patients where you can more easily show a beneficial effect because the mortality is higher. With Emily, and a group of young investigators, we then looked at what we know about the use of non-catecholamine vasopressors on the kidney, and this is a very nice analysis. It was recently published in Shock, looking at all the experimental studies and showing that the use of angiotensin II, but also the use of vasopressin, are associated with better renal outcomes compared to catecholamine-based resuscitation and vasopressor therapy. And this is a cartoon which highlights that both vasopressin and angiotensin II share a common effect on the efferent arteriole, which may be responsible for the improvement in GFR in vasodilatory shock. That's the kidney. Does angiotensin II have a beneficial effect on other organs? Again, we got the human model of sepsis, this time with ARDS. This is a study conducted in the subgroup of patients in the ATHOS trial that had ARDS. And this is what you can see when you compare the treatment with placebo to the treatment with angiotensin II in terms of the PF ratio and the oxygenation, the PaO2 and the FiO2. And as you can see there's a unique effect on oxygenation, which is independent on any effect on ventilation or mechanics that leads to an improved gas transfer across the lung with angiotensin II. And then there is another organ that is affected by angiotensin II. So we don't just have the cardiovascular effect, the renal effects, and the respiratory or pulmonary effects, but we got effects on bacterial clearance. So there is an immune effect of angiotensin II. This is in a mouse model of cecal ligation puncture, and you can see the effect of angiotensin II in blue. So there is an effect on the release of tumor necrosis factor, which is diminished at 48 hours compared to vehicle, and compared to angiotensin II plus losartan to block its effect on the angiotensin type 1 receptor. And you can see there is a clear effect of angiotensin II on interleukin 1 beta, on interleukin 6, on interferon gamma, on interleukin, tumor necrosis factor, and a variety of other markers of immunological activation. What about bacterial clearance? Does angiotensin II affect that in the mouse? Again, they have the same model, and you can see that the bacterial clearance achieved with angiotensin II is significantly different, and you can see there is a blockade of that with losartan. What about the ability of neutrophils to generate radical oxygen species to kill bacteria? Again, you can see the vehicle, and you can see in the middle the effect of angiotensin II compared to angiotensin II versus the vehicle versus angiotensin II plus losartan. And the same is true of monocyte activation. There is a clear immune effect of the administration of angiotensin II, which is blocked by angiotensin receptor 1 blockade. And when you're looking at the phagocytosis, and you can see that after stimulation with lipopolysaccharide, you can see the middle kind of pink-colored effect that you can see with angiotensin II. There is activation of phagocytosis with CLP model, with stimulation with lipopolysaccharide in non-infected animals, and in infected animals, which is blocked by the administration of losartan and is different from that of vehicle. And this is the punchline. When you do bacterial counts from the peritoneal cavity, and you've given intraperitoneal angiotensin II, no antibiotics, just angiotensin II. This is what happens to your Petri dish. And if you give angiotensin II subcutaneously, this is what happens to your Petri dish of your intra-abdominal cultures. And if you give angiotensin II plus losartan to block the effect of angiotensin II on the angiotensin type 1 receptor, this is what you get on the Petri dish. So there is an independent effect which is mediated by activation of the receptor of angiotensin II on bacterial clearance. So let me conclude my presentation, and I hope that I've been able to show you that angiotensin II has pervasive vital organ function effects. We're all familiar with the cardiovascular effect of restoring blood pressure. That's what we give angiotensin II for in the setting of vasodilatory septic shock or other forms of vasoplegic shock. So those cardiovascular effects are well known. I hope that I convinced you by showing the effects in the sheep model, in the mouse model, and the human model that there are beneficial effects of angiotensin II on renal function that are likely to be mediated by efferent arteriolar vasoconstriction and restoration of intraglomerular pressure, which is responsible for delivering GFR. I also hope that I've been able to convince you that there are effects in the human model of angiotensin II on pulmonary function, particularly in relation to oxygenation and oxygen transfer. I also hope that I've been able to show you that in the animal model, we don't know yet about the human model, there are clear immune effects which are there to enhance bacterial clearance and the activity of neutrophils and monocytes in terms of phagocytosis and in terms of radical oxygen species. Thank you very much.
While we are waiting for Ashish or anybody else to ask a question, let me ask you a question. So a couple of hours ago, Jan Bakker talked to us about choices of pressors. And he started the way every single talk starts and every guideline starts with norepinephrine is first choice. And he starts that out by saying norepinephrine has been compared against dopamine, against epinephrine, and norepinephrine is better. And so it's first choice. Just to be provocative, understanding that a couple of talks from now is when do we use angiotensin II? Should angiotensin II, based upon what you just said, be the first choice pressor rather than the second one we add?
That's a very legitimate question. I don't know if Emily has just left, but yeah, there she is. Emily is conducting a randomized controlled trial, a phase 2A trial, which is aiming to recruit 200 patients, where angiotensin II is used as the primary vasopressor agent. I think, Emily, we've done about 86, 87 something patients so far. We're coming up to the first interim analysis for 100 patients soon. And the answer is we're exploring it.
I think there's a question in the back, but I can't tell because the lights are really bright. I can't tell if somebody's...
I don't think Ashish likes me. I'm just waiting for him to ask, and he's not. I'm really disappointed.
Daniel, but there is another person.
I can't tell if there's somebody in the back raising their hands. Lights are kind of bright up here.
Yes, may I speak? Roman Kula, Czech Republic. I'm still a little bit concerned about renal tubular cells when there is a constriction of efferent arteriole. Could it possibly lead to some tubular ischemia and necrosis?
Very good question. So we studied that in two different ways in the sheep. One is by measuring oxygenation of the medulla and the cortex during the administration of angiotensin II in the model of sepsis, and studying that by the presence of intra-tissue oximetric probes. So we take the animal, we install the probes, then the animal recovers from the surgery, then we deliver gram-negative bacteria, we do shock, and the answer is there is no change in oxygenation compared to placebo. But if you give noradrenaline or norepinephrine, there is decreased oxygenation of the medulla in the same model. So that's the first thing. And the second one is we put the animal in the magnet to measure ATP. And both of these works are published. And during angiotensin II administration to restore blood pressure, there is no significant loss of ATP in the kidney tissue either. So that information suggests to us that desaturation of the medulla and the cortex with angiotensin II infusion is unlikely to happen.
Daniel?
The improvement of oxygenation with angiotensin is likely mediated by the enhancement of hypoxic vasoconstriction. So because there is no change in compliance and others with the angiotensin. So what is the risk there of leading to acute cor-pulmonale? Because with almitrane you have the same, but you have an increased risk of acute cor-pulmonale.
So that's a very good question, and we have not seen that. Like, as you know, in the ATHOS trial, we haven't seen any acute evidence of right-sided heart failure. I mean, we saw that kind of stuff with LNMMA. You might recall from the good old days when people try to block nitric oxide synthase. We haven't seen that kind of effect with angiotensin II, but I take the point that you're obviously changing the pulmonary resistance vessels in the setting of lungs. But clinically, it hasn't played out. That's not to say that there mightn't be some patients where that becomes a factor, but we haven't seen that. Yeah.
Rinaldo, you show very, very positive results in favor of angiotensin II administration. But I have a question: were the doses used in all these studies comparable, and is there some dose effect depending on the organ, for example?
So the doses are clearly different because you're trying to achieve a target blood pressure in the resuscitation of the animal. So you're trying to restore blood pressure to the goal that you had in the management of and the patients are all going to be different. So some patients will require 5 or 10 nanograms per kilogram per minute. Some people will require 80. And so there is a spread of values, but then that's partly driven by the severity of illness. And so it's really difficult to have a kind of a dose thing. But this, at lunchtime, we presented the recent paper in critical care where we showed the aim right concept, where you actually take the patient, and the patient has a blood pressure at time 1 hour after angiotensin II infusion. You subtract the baseline blood pressure, you divide that by the dose of noradrenaline, and we demonstrate that if you got a ratio there about 0.9, then you're significantly more likely to live if you are such a responder, if you continue with angiotensin II. So in terms of the dose, it doesn't matter because we can see what's happening to that ratio, and if the ratio is a responder ratio, you should continue it because there is survival advantage.
And just one quick final question. We use angiotensin II a lot, and a significant number of our patients are entirely non-responders.
Yes,
and
absolutely.
that's entirely an anecdotal thing.
I agree, yeah.
What percentage of patients do you see are responders versus entirely do not respond?
In the AIM-RIDE study, in the ATHOS trial, it's at the order of about 50%. Yeah, similar to that kind of value, yeah. But of course, if you intervene early, like Emily is doing, and you're giving it immediately as a first-line vasopressor, as soon as somebody arrives in the intensive care unit, then it's a different story. Then it's a different story.
Thank you very much.
So we move to the next presentation by Peter Pickers from Netherlands, and again talking about angiotensin II, but in renal failure.
Thank you very much, Chairman. I think for the people that were here during the lunch symposium, that was very nice, and the previous talks, there are only this number of clinical studies, and so there will be a lot of repeat. But I think repetition is the most important lesson, so it's not that bad. And I will focus a little bit more now on the effects on the kidney, and so angiotensin II in renal failure. Which patients might benefit most? And indeed, the ATHOS 3 trial was the trial that started this all. And I think it's good to emphasize that in the end, 72 patients were followed up in one group and 88 in the other group. So this is a relatively small trial, but a tremendous amount of information has been gained from this trial. What was done in this trial was that angiotensin II was given to patients that were already on norepinephrine. And as you can see, it's an effective vasopressor. Blood pressure goes up. As a consequence, you need less norepinephrine in these patients. So there is a catecholamine sparing effect over time. And the Kaplan-Meier curve is deviating, actually. But of course, with these small numbers of patients, this is not a statistical significant effect. But still, the benefit is of clinical relevance if this would turn out to be true in larger groups as well. So this is all beneficial. So which patients may benefit most if you have to look for patients that might benefit? And what I said earlier, that during sepsis, the kidneys are trying to maintain a GFR. And it's doing so by dilating the afferent arteriole, and this is a prostaglandin-dependent mechanism, and at the same time increasing vascular tone, constricting the efferent arteriole, and this is mainly mediated by angiotensin II. And this way it's increasing filtration fraction and GFR will be maintained. So we're clearly not giving these drugs, prostaglandin inhibitors, in sepsis patients. Why? Because this vasodilatory effect of the prostaglandins will be nullified by these drugs, and so there will be constriction in the afferent arteriole as well, and your GFR will drop. We've seen that in patients. And at the same time, we do not give ACE inhibitors to patients with sepsis for the same reason, that the constriction of the efferent arteriole will be nullified. And then again, there's a decrease of pressure and filtration fraction, and GFR will drop. So the opposite could be true as well, that if you are in septic shock, vasodilatory shock, that there might be a shortage of your endogenous mechanisms that are increasing vascular tone. And if it's indeed angiotensin II that you have shortage of, the kidneys might also suffer from that. And then if you give angiotensin II to these patients, you might be able to constrict your efferent arteriole again, and GFR might be preserved. And the group of Rinaldo did tremendous amounts of work and beautiful work on this compound. And indeed, if you give angiotensin II in animal models of hyperdynamic sepsis, urine output increases and also creatinine clearance increases. So indeed, this is a positive effect on kidneys. So are there indications that patients with impaired renal function might also benefit more from angiotensin II treatment? And indeed, this was one of the first post-hoc analyses of the ATHOS 2 trial, that if they looked in a subgroup of patients that were already on renal replacement therapy at the moment of enrollment in the trial, and this is 45 against 60 patients, that the time to liberation of renal replacement therapy was shorter in the ones that were treated with angiotensin II. Again, this was a significant effect, and if you looked at the survival curves of this subgroup of patients on renal replacement therapy at the moment of enrollment, in this subgroup, small numbers, but there was a significant benefit in survival if they were treated with angiotensin II instead of only norepinephrine. So there's a benefit for patients, but maybe not only for patients already on RRT. So we did an additional study, and we looked at patients with different severity of AKI, and what we found indeed that overall there is an effect. There's clearly an effect on renal replacement therapy patients, as I mentioned earlier, but also AKI stage 3, not yet on renal replacement therapy, have a benefit in the number of renal replacement therapy free days. There's no benefit in AKI stage 2 and 1. But clearly, if you have stage 1 or 2, the chances that you would need renal replacement therapy are pretty limited in the first place, so there's little benefit actually to gain in renal replacement free days. And again, also there is a statistical power issue with only 25 patients with AKI stage 1, 42 with stage 2, while the numbers that were on renal replacement therapy and stage 3 were larger in this trial. So I'm not sure if it does not work in patients with stage 1 and stage 2, but the numbers are too small to say anything at this moment. So indeed, patients with impaired renal function appear to benefit more from angiotensin II compared to norepinephrine. And there's another group of patients with organ dysfunction that might benefit more. And these are the patients with ARDS. And we know that there's a lot of ACE in your lungs. And we know that during sepsis, your angiotensin converting enzyme is not functioning well. And interestingly, if you have a polymorphism of the ACE gene, you're more likely to suffer from ARDS. And indeed, in this study, that was a cohort without a control group, if they aligned the patients from the moment T0 when angiotensin II was started, you can see that over time, their norepinephrine infusion rate was increasing, and then if angiotensin II is started, it's decreasing. So this is a confirmation of ATOS 3. But more interestingly, if you look at oxygenation over time, it's also getting worse prior to the start of angiotensin II, but then if you start it, PF ratio is improving. And again, the number of patients with a PF ratio of 300 or less was increasing prior to the start of angiotensin II, and then it goes down if you start it. Now, you would say, well, this is a case series and there's no control group, and maybe it's just a natural course of the disease. So, of course, again, another clever post-hoc study of the ATOS 3 data, because there were 81 patients with ARDS at baseline. And then, as already alluded to by Rinaldo, in those patients, we could compare against norepinephrine alone. And indeed, PO2 goes up, FeO2 need goes down, so PF ratio is significantly improving compared to norepinephrine alone. And what Jan Bakker was asking, indeed, hypoxic vasoconstriction, etc. But it could also be that I think that you have like within the organ differences between different vascular beds, and that there's like regional vasoconstriction or not, and that you could have a better match between vascular with perfusion and ventilation. As a consequence, you will have better oxygenation. And of course, with these numbers, only 81 patients with ARDS at baseline. If you look at survival, well, there is maybe a signal there that is less, that mortality is less in these patients, but the numbers are way too small, of course, to have any significant relevance. So how can we use it? I think there are several things. I think it's clearly the case that at this moment, we don't know if there are benefits in all patients, mainly as a first choice vasopressor, as now is being indeed investigated. So you have to look for a subgroup of patients, not to give it to everybody. It would be maybe too expensive as well. So if your patient is using an ACE inhibitor, and then you're more likely to have shortage of angiotensin II endogenously, then it's working better. If the dose of norepinephrine that is starting is low still, then it's working better. If your renin level is higher, if you have an increase in blood pressure on angiotensin II, it's more likely to have a survival benefit. If you have AKI stage 3, or you are on renal replacement therapy, or you have RDS, these are the ones that might benefit more. So I think we could use that in clinical practice at this moment to enrich our patient groups and say, well, these are the ones that appear to have a more pronounced benefit, and especially for this talk, the ones with renal or pulmonary dysfunction. So my conclusions are that there are now alternatives for norepinephrine, and angiotensin II is a very good one, and so far no safety issues emerged. We heard in previous talks that at the beginning there was a suspicion that there might be a coagulation issue or thrombosis issue. Is not there, what we see at this moment. And everything that the post-hoc studies show makes sense. It's all logical. So the subgroups, the effects of pre-existing treatment with ACE inhibitors and receptor blockers, and so there are theoretical and preliminary indications of benefits, and this is also the case in patients with AKI and ARDS. But also very importantly, this is all based on post-hoc analysis of a relatively small study. And so we do need confirmation of this. But in the meantime, I think if you do want to use it, but not in all patients, the ones that were using an ACE inhibitor prior to their ICU admission, the ones that do show an increase in blood pressure if you start angiotensin II infusion, the ones with AKI and the ones with ARDS, these might represent the ones that have more benefit, but we need confirmation. Thank you very much.
Thank you. Questions? I have one. Finally, if I want to understand, the effects on the kidney of angiotensin II is mainly due to the action on the efferent artery.
Correct.
This is more or less the same as vasopressin. So do you have in mind some data comparing vasopressin and angiotensin II on the kidney function in patients with acute kidney injury or in experimental studies?
Well, there were indications that indeed vasopressin was also beneficial for the kidneys. This was actually tempered when the celepressin trial was done. So this was a trial with a selective V1 agonist. And in that trial, it was like 700-800 patients, I think. There was no effect whatsoever on the incidence of renal replacement therapy or duration, etc. So it was not confirmed there that there was a beneficial effect on the kidneys. But of vasopressin itself, there were some indications. The difference, if you compare the two second-line vasopressors, vasopressin versus angiotensin II, I think we learned so much more of all the post-hoc analysis that were done and that they make sense. This is a little bit missing for the vasopressin studies, I think. And it would be nice to actually use the same tactic and also to look in subgroups of patients on renal replacement therapy or with ARDS, etc., etc. But we don't have much of that. And as you were saying, Craig, already, that indeed some patients show no response. But some patients, even ones with very high norepinephrine infusion rates, and think, well, it's not working at all anymore, and you start angiotensin, it's amazing how they're still responding on angiotensin II. So you can't tell. And I think the new trial that was just published a couple of weeks ago is actually the most important one. I love it because the earlier message that you should measure renin levels, and then if it's high, it's more likely that it will work. But every hospital had problems with measuring renin, and then it's not possible outside of office hours, or et cetera, et cetera. And then what is the actual threshold and all these kinds of stuff. I think if you have, it's typical intensive care medicine, if you have like a test dose, and you see an increase in blood pressure, and you know it works, and now it has been shown by Rinaldo and his group that relates to a better survival, then that's the easy way to go. You have a test dose. If it doesn't work, you stop it again. If it does work, you continue, and you know that there's better survival. That will be the game changer in the use of this drug.
Ashish? Microphone, please.
You are limited to 7 questions.
Now that I have permission from Craig, importantly. So last point you made, I want to controversially just pick that up. I wanted to ask Rinaldo too, but Craig was looking at me, so I was scared. The issue is, how do we titrate or decide on angiotensin II at the bedside? I love the AIM-RIGHT index that Dan Leisman has come up with, but that is post-hoc analysis from Athos and basically shows if you give angiotensin II, blood pressure is increasing, oh, that's a responder. You could make that argument for vasopressin as well. You could make that argument for norepinephrine as well. I give norepinephrine, blood pressure increase in a robust way, then that patient is a norepinephrine responder, right? So it's very difficult for me to bring up 3 vasopressors, test all 3 of them, see which made the blood pressure go up the most, and then pick on that. I would love to do it, but it's not practical. I would also love to get renin at the bedside and then give Ang2 and see a renin response and decide on the basis of that. But all of this seems very complicated right now. Is there an easy way to do this?
Yeah, so what I was saying is, indeed, I think the blood pressure response way is like the very easy way. Everybody can do it. You don't need any resources. It's something that you see right away. And the important thing is that it's related to benefit and survival. And I think that's not always the case, that we have seen that if you respond with a short-term hemodynamic effect on the drug and it's supposed to do what it's doing, that you actually can translate that to a survival benefit. So this is the difference, I think, compared to what we had before. With vasopressin, the response is much less pronounced and takes longer, etc. And the other thing that you ask is that, so how should you titrate it? So there's no data. We don't know what is the optimal way. What we do in our hospital is that, so some patients have like dangerously high norepinephrine infusion rates. So you would go up and you would just use the doses that are in the IB, and then use the maximum dose of angiotensin, 40 nanograms, for example, and then you go up to that if norepinephrine is really high, and so you can lower it. And if you like, and then the other question is, the nurses really ask, they're on norepinephrine, they're on angiotensin II, and the patient is getting better, how should they taper the drugs? Which one first, to what extent? And what we now do is that we aim to taper then first norepinephrine, and then until like 0.1 microgram kilo per minute. That is like sedation compensation, and then taper or stop angiotensin II, and then so you go down with norepinephrine to an infusion rate that you're absolutely fine with. But these are things that are just practical advices. We have no data whatsoever what would be more beneficial.
Thank you very much.
Our next talk will be our final talk on angiotensin II. Angiotensin II for which patients, by Massimo Girardis. Again, I apologize if I pronounced that wrong. American, ignorant, coming from Italy.
Yeah, thanks so much, Mr. Chairman, dear colleagues. Good afternoon. It's quite difficult to say something new after this presentation on angiotensin. I will do my best for giving you some practical advices on the use of angiotensin. But first of all, I repeat my disclosure. First of all, I want to start with the guidelines, but I prefer to present you the evidence behind the use of vasopressor in hypotensive shock. As you know, this is the Cochrane Library. This is a sort of guarantee for the appropriateness of meta-analysis production. And they concluded that we have no clear indication that one vasopressor is better than another, or a combination of vasopressor is better than one vasopressor in terms of mortality in patients with hypotensive shock. And interesting, they concluded that it's time to change our approach, not to selecting 1 or 2 or 3 vasopressors to make a comparison in a randomized controlled trial, but to select the appropriate patient with his history, his pathophysiology, and of course, the use of vasopressor. In a way, a sort of, the first time for me from Cochrane, a sort of personalized medicine suggested by the Cochrane group. And we know that the patient with hypotensive shock, septic shock particularly, are not similar, but we know also that the drugs that we use, in this case our vasopressor, are not similar. And as well presented, I think, during this afternoon, we have many different effects at the vascular level, in other sites, and importantly, in the domain of sepsis and inflammatory response, giving us all the effects on organ dysfunction, is the effect on the immune system. And in this light, I think that it's important to consider that when I start a vasopressin in my patient, I have to control, to check all the other sites, organ, and functioning, including endothelial and immune response. We try to have just a look to the literature and summarize which is the patient who can benefit the most from the use of angiotensin. And as I presented before, we selected 3 different populations, subpopulations of patients with septic shock. One is, as we know now, all the patients with acute injury requiring renal replacement therapy, clear advantage in using angiotensin compared to increase of noradrenaline or the sum of noradrenaline plus vasopressin. The group with the high renin level, with all the problem in measuring renin, as Peter said before, and patient with low vasopressor requirement. As we talked this morning, this is not only a problem of amount of vasopressor, but probably is a problem of time for initiation of vasopressor. As we said this morning, this is the same picture that we have with vasopressin. The data come from VAS trial, 15 years ago, and has been renewed by the new publication of his trials yesterday morning. I guess that briefly looking to all the trial that has been presented, I guess that renin should be considered by the practical view as a proxy variable. And proxy variable is very practical in the hospital because it's quite difficult to measure angiotensin 1:2 ratio. But renin is more available in many hospitals in the working days and could be an indicator for selecting angiotensin rather than vasopressin as second vasopressor. Of course, it's not used for biomarker in many other hospitals, but if you have the possibility to have this biomarker, it could be a very good way for using vasopressor, angiotensin. The second group of patients is patients receiving angiotensin converting enzyme inhibitors. You know that from the secondary analysis of the ATOS trial, they observed in a very small group of patients receiving inhibitors of the ACI receptor before shock that in this specific population, the effect of angiotensin is very important, it's more pronounced than in patients that are not exposed to inhibitors or in patients that receiving receptor blocker as an antihypertensive drug, as expected. The most important part of this story is that we have a sort of good data and expected data from pharmacodynamic of a drug and from the pathophysiology of the patient. The third group of patients that we selected was the patient with low norepinephrine dosages when you have to start with a second vasopressor because you have, for example, some adverse event by using one vasopressor. Very practical example, if you start noradrenaline in your patient develops some arrhythmia, tachyarrhythmia. It's time and the pressure is still hypotensive. You try to manage your arrhythmia, but in the same time, you have to increase blood pressure. And at that time, probably the use of angiotensin very early could be beneficial in this population. And this is in the same story, in the same line of the multiple approach, multimodal approach that I will talk at the end of my presentation. Just one piece more of knowledge concerning the use of angiotensin in patients with acute respiratory failure and RDS specifically. We know that the stimulation of angiotensin receptor 1 may cause hyperinflammation, whereas the stimulation of angiotensin receptor 2 can cause hypoinflammation. So the net balance in patients with ARDS is difficult to say, but I believe that is one of the reasons why we could observe in a specific part of the population with inflammation causing ARDS beneficial effect in PF improvement in oxygenation beyond the vasoconstriction or hypoxic vasoconstriction. Just another practical experience in our first patient in our center by use of angiotensin. We measure with a PAC catheter all the pulmonary vascular resistance, but using angiotensin, we did not observe any increase in pulmonary vascular resistances, whereas we observe a very important increase in systemic vascular resistance. So this is, I think that hypoxic vasoconstriction is a part of the story, but looking to data on COVID and non-COVID-19, I guess that there is something more on inflammation or sort of modulation of inflammation, but it should be, of course, demonstrated by appropriate studies. Finally, I want to present you our practical approach to how to select the second or the third vasopressor in patients still hypotensive after the initiation of noradrenaline. That is still the first line therapy. I think in all the hospitals, we start with, we decide to have a protocol because, of course, to avoid the heterogeneity between different physicians or different believers or not believers of angiotensin and vasopressin. And as you can see there, if you have a patient still hypotensive after noradrenaline without signs of cardiac dysfunction, we put a second level monitoring. A second level monitoring means transpulmonary thermodilution or transcardiac thermodilution. And if we have specific condition, as mentioned before, a patient with high renin level, we have the opportunity to measure renin level during the working days from 8 o'clock to 6 o'clock in the afternoon. In 2 hours, we have the results. Patient with very low level of noradrenaline, ARDS, or patient receiving ACI before treatment, we select a second vasopressor angiotensin the second. If not, we prefer vasopressin, and to shift in angiotensin as a third vasopressor if we have harmful or not clinical improvement by using vasopressin, or some adverse event, as for example digital ischemia or hyponatremia caused by important hyponatremia caused by vasopressin. I want to conclude with another practical aspect, that is the dosages, and is the equivalent dosages of angiotensin. This data come from the Aramis trial. That it was a preliminary study on the use of angiotensin as a first vasopressor, and using data of noradrenaline before the initiation of angiotensin, the authors were able to make a sort of equivalent dose, and at the moment, this is quite important. Equivalent dose means that when I start with angiotensin, the expected effect is for each 1 microgram of angiotensin, I expect to decrease by 10 micrograms per kilo per minute of noradrenaline. And this is quite stable in all the patients, but the patient with receiving before shock antihypertensive drug receptor block, where the comparison is 1 to 5, 1 to 7. I want to conclude with my 2 take-home pictures. The first one is that finally we have a third vasopressor that we can use in our patient for achieving the so-called catecholamine sparing strategy, this multimodal approach for decreasing the effect that we have in many patients requiring high dosages of noradrenaline for maintaining the blood pressure, and all the negative effects in terms of arrhythmia, increase of oxygen consumption of the heart, all the immune effects, increase in bacterial growth caused by noradrenaline. Angiotensin should be considered in light in this multimodal that are also where you can find also other strategies that could help us to decrease the impact of noradrenaline. And finally, this is in honor of the land of where I live. This is Modena city. Modena is a Ferrari town, but they learned me that sepsis sorry, that team working is quite important, and sepsis, I think, is a high precision team working. Thanks so much.
Thank you for a remarkably practical talk, and I love the good jobs on the side. I have a question, and it's based upon anecdotal experience. I work in a nice 23-bedded ICU, and about half the patients are liver patients. And in theory, somebody with acute on chronic liver failure, cirrhosis going to sepsis, is high output vasodilatory shock. In our experience, angiotensin II almost never works in liver patients, so much to the point that we've actually started using methylene blue as our third-line agent because it basically never works. But that's an anecdote. Are you having a similar experience?
Yeah, definitely. Not similar, but you know, we have a big liver transplant center, so we have many of cirrhotic patients with liver failure before and or after the transplantation. In our experience, the use of angiotensin together with vasopressin and noradrenaline help us to have some resolution of the problem. Angiotensin with noradrenaline in this specific category of patient is not enough, probably. So we need probably more than 2 vasopressors. This is our experience in maybe 5, 10 patients.
Thank you. Questions from the audience? Okay, that will conclude the angiotensin part of this, but this does not conclude the session. We've got 2 more outstanding speeches. Thank you very much.
So now we move to another drug, I would say, another vasopressor, metaraminol by Ary Serpa Neto. So still a place for metaraminol. Ary?
Thank you very much. Thank you very much for the invitation. It's a pleasure to be here. So I don't have any specific disclosure related to this presentation. And before discussing the metaraminol, I would like to just review and discuss a bit the use of peripheral vasopressors, because I think the use of metaraminol is 100% linked to the use of peripheral vasopressors. And as doctors or physicians, we are really afraid of this extravasation injury. So every time we consider like a peripheral infusion of vasopressors, our biggest fear is extravasation. And extravasation is basically when a drug leaks from the blood vessels, and major risk factors are related to drug and are also related to patient characteristics. So why is this important to patients receiving vasopressors? So first, because all vasopressors are in acidic solutions with pH ranging from 2.2 to 6.5, and lower pH is highly associated with extravasation injury. And the other reason is that because all patients needing vasopressors, they have shock, and decreased perfusion to periphery is highly associated with extravasation injury. So every time we decided to start a peripheral vasopressor, we have a very high risk of an extravasation injury. So this is why central lines are often preferred, but it's not always possible to obtain a central line, and it's not without risks. So it's really hard for us to predict patients that will need a central line. So this is one study suggesting that male patients after a cardiac admission, they're basically less likely to need a central line. And intubated patients with renal dysfunctions are more likely to need a central line. However, the discrimination and the predictive power of this model was really low, so it's really almost impossible for us to predict. And it's always really important to remember that the risk of inserting a central line is really low, especially with the use of ultrasound, but you still have risks like vascular complications, pulmonary complications, device dysfunction, infection, compared to a very low incidence of extravasation with the use of peripheral vasopressors. So this is a big systematic review investigating the incidence of extravasation with peripheral vasopressors. And the incidence was really low and associated with prolonged infusion and especially with IV position. We don't have time to go through all these studies, but this is just a summary of different studies investigating peripheral vasopressors. You can see mainly US and Australia. The main drug was always noradrenaline. Metaraminol is present only in Australia, so 18% of the patients received metaraminol. The duration ranging from like 7 hours to 48 hours. The extravasation rate from non-zero to 13% in one study. And most importantly, the prevention of a central line placement ranging from 20% to as high as 90%. But all these studies concluded that usually peripheral vasopressors are safe if used for a short period of time and with proper monitoring. Usually, most of the patients receiving peripheral vasopressors on day 4 in this study, you can see that 36% of the patients were off pressors, and only 13% of the patients needed a central line and central infusion of vasopressors. So when we decide to start a peripheral infusion of vasopressors, if we select the right patient, it's very likely that they will probably not need a central line, and they will be, after some days, off pressors and without a new central line. And the incidence of adverse events, not only extravasation, but general adverse events associated with the use of peripheral vasopressors is really low. So this is another systematic review reporting an incidence of 1.8% of adverse events related with a peripheral infusion of vasopressors. So overall, peripheral vasopressors, they are safe. There's a low risk and low rate of extravasation. Using peripheral access enables an earlier initiation of vasopressor therapy, and they potentially reduce the need of CVC placement and its associated complications like infections. And why metaraminol? So first, just reviewing the pharmacology of metaraminol, we need to remind that it works through an indirect effect. It's a noradrenaline-releasing agent. It's an alpha-1 agonist, but if you use very, very high doses, you can have some beta-1 agonists, but it's only in very high doses, what we don't usually do in our clinical practice. So it's mainly an alpha-1 agonist. You can use as boluses or in continuous infusion. The main side effect is a reflex bradycardia, and advantages are, one, it can be bolused, and it can be given peripherally. So why? So the pH of the metaraminol is higher than the pH of the noradrenaline, and if you remember some of my previous slides, I just said that a lower pH is associated with a higher risk of extravasation injury. So metaraminol has a higher pH compared with noradrenaline, and it's a less potent vasoconstrictor agent. So if it's a less potent vasoconstrictor agent, its risk of extravasation injury is also lowered compared with a more potent vasoconstrictor like noradrenaline. So comparison with other vasopressors. So first thing, old study just showing that metaraminol is a vasopressor. So as a vasopressor, is able to increase the blood pressure. So compared to noradrenaline, vasopressor increase arterial pressure. So it's good. It works as proposed. This, and then we just have matched and retrospective and observational studies. So this is a matched study comparing resuscitation with metaraminol and with patients receiving resuscitation without metaraminol. In this specific study, matched study, the use of metaraminol may be associated with a longer time to resolution of shock, but it's hard to understand if this is because of the drug or because the patients who received metaraminol were sicker, and even with the matching, it's sometimes impossible to correct for that. Another thing that is really important for us to consider when considering metaraminol is the cost. So in this study, the metaraminol use was safe and highly effective, but the costs were higher compared to peripheral noradrenaline. So if you're able to use peripheral noradrenaline and if you're comfortable with, maybe the cost will be lower. And there is very limited and low quality efficacy and safety data to support the use of metaraminol, like especially when we talk about high quality clinical trials. Regarding the dose equivalence, especially with noradrenaline, so this is the first study assessing the dose equivalence of metaraminol to noradrenaline. This study report 1 to 8, so 1 mic of metaraminol to 8 mics of noradrenaline. This is a second study investigating the same thing. In this second study, the equivalence was 1 to 13. And we did a study in Melbourne investigating that, and we also found 1 to 12, 1 to 13, depending on different conditions. And if you have a patient with acute kidney injury, the dose equivalence was 1 to 14. So metaraminol can be administered as boluses or as a continuous infusion. It's safe for peripheral infusion. And although the evidence is limited, the available data suggests it is at least equivalent to noradrenaline, but attention to cost. And the dose equivalence to noradrenaline is approximately 1 to 8 to 1 to 13. What is the current clinical practice? So the use of peripheral vasopressors, this is a survey investigating the use of peripheral vasopressors. You can see, like in the US, 90% of the respondents said that they use peripheral vasopressors, while in the UK, only 30-40% said the same. The drug is also different among countries. So you can see in the US, most of the doctors or respondents said that they use phenylephrine, while in Canada it's mainly dopamine, and the UK and Australia it's mainly metaraminol. So it looks like metaraminol is it's more common, at least in Australia and the UK. Most of the respondents, or 50% of the respondents, said that they had a protocol for a recommended maximal duration of peripheral noradrenaline, up to 24 hours with a concentration of 16 mics per ml, and with a maximum dose between 11 to 20 mics per minute. For other vasopressors used peripherally, not NORAD, they basically said that also the duration that they were comfortable with was 24 hours with an IV drip proximal to the antecubital fossa, and most of them had a treatment guideline for extravasation. So patients, so when I'm comfortable with using metaraminol, so basically this study suggested that patients, when anticipated a short duration of shock or low dose of vasopressors, only to provide support until a CVC can be inserted or when a CVC was not available. Regarding the type of patients, so mainly post-operative elective surgical patients admitted to the ICU or patients shocked pending further diagnosis, where treatment was limited to a peripheral infusion only, or mainly with sedation related to hypotension. So in all these scenarios, the respondents said that they would be happy to use peripheral vasopressors. The dose was pretty much the same, metaraminol up to 7.5 milligrams per hour and noradrenaline up to 0.4 micrograms per kilo per minute. And the duration was different. So the respondents, they were comfortable with using noradrenaline peripherally for up to 24 hours, while with metaraminol, they were happy to use up to 48 hours. Clinical study, so this is the ARISE trial, so 11% of the patients in the ARISE trial were using metaraminol at randomization, 15% using a peripheral cannula. And in this new study from Australia in the emergency department, you can see that 47% of the patients with sepsis were receiving a peripheral infusion of vasopressor in ED, so almost half of the patients, for a duration of 5 hours. And metaraminol was used in 40% of the shocked patients, septic shock patients in ED in Australia and New Zealand. In the US, this is the Clovers study, so almost 65% of the patients received peripheral vasopressors in Clovers. Noradrenaline was used peripherally in 20% of the patients, and extravasation was really low, was 0.6%. This is another trial in Australia investigating restrictive fluid resuscitation. In this trial, peripheral vasopressors were used in 50% of the patients. Noradrenaline was the most frequent drug, and metaraminol was used in 15% of the patients, and no extravasation was reported. And a pharmacoepidemiology study done in Australia, so you can clearly see here pretty much the same as we reported 2 slides ago. So metaraminol was used mainly in surgical patients in the post-operative period with a peripheral administration in 100% of the patients. Only 15% of the patients who received metaraminol needed a central line, so it was basically able to prevent a central line insertion in 85% of the patients. The duration of metaraminol infusion was 12 hours, and the ICU mortality was 6%. So overall, the current clinical practice, the use of peripheral vasopressors, including the choice, duration, and the infusion limits varies across regions. The ideal candidates are patients with low severity, like post-surgical, and with an expected short duration of vasopressor therapy. And when administered, close monitor is essential with predefined maximum dose and duration, and a CVC should be promptly inserted if necessary. In our clinical practice, we have a threshold of 48 hours, and a maximum dose of metaraminol of 100 mics per minute. So just to quickly finish my talk, so with the opportunity, so guidelines are needed, and we need to discuss peripheral vasopressors in our guidelines. It's not very often discussed. So this is just an example of a guideline describing how to use, where to place the IV cannula, the duration of infusion, and even the concentration of the drug to be used, and the dose of the drug that is allowed to be used in peripheral infusion. We have a limited high-quality studies and clinical trials investigating peripheral vasopressors and metaraminol. There's a lack of discussions on metaraminol's role in key guidelines and recommendations. It's not included in SOFA score, at least in SOFA 1, the score that we still have. And the affordability and availability should be also taken into account. So to conclude my talk, metaraminol is frequently used, especially in Australia and in the UK, despite limited evidence, and it's really normal in Australia for us to use metaraminol, but for example, in Brazil, another country that I trained and worked, we never used metaraminol. And emerging safety data at least support peripheral administration, and metaraminol is an excellent candidate for peripheral vasopressor therapy. Thank you very much.
Thank you. Questions? Maybe I missed the point, but maybe you show the slide and the study, but it was very, very fast. Studies looking at hemodynamics with metaraminol, I mean cardiac output, etc. Do you have data? Because there was a study by Natalini.
There's not a lot of data. The only data that I reported here was the one in septic shock, like from 2005, reporting mainly like cardiac output, mean arterial pressure. The effect was pretty much similar to noradrenaline. The only thing is that most of the time my experience is that you need much more metaraminol than noradrenaline to achieve the same numbers.
And do you have some idea about the role of metaraminol on venous return and venoconstriction?
No, we don't have a lot in the literature reporting that, yes. No.
Because noradrenaline can do this.
So this is why I think like if you have a complex patient where you think that a vasopressor have like to understand and to apply the complex physiology, metaraminol is not the best choice. It's usually, my experience is that it's pretty good in like patients after surgery needing very small dose of vasopressors for like 12 hours, or after like epidural and a bit of hypotension or sedation-related hypotension. But if you have a complex like septic shock patients, usually metaraminol will not work properly. You have quickly to switch to noradrenaline and put a central line.
For example, for compensating sedation.
Exactly, yeah.
Okay. If there is no other question, maybe thank you very much.
Thank you very much.
To the last presentation.
So our last speaker, thank you everybody for sticking around. This is obviously a marathon, nearly 4-hour session, so thank you very much, and thank you to all of our speakers before Ashish speaks, so thank you very much. So our last speaker should hopefully also need no introduction, and even though he's speaking on venous vasopressors, is actually the first author of the ATHOS 3 trial. And Ashish Khanna will talk to us about emerging interest for venous vasopressors. My friend Ashish, take it away.
Thank you, Craig and Jean-Louis. It's always the best option to be the last speaker in the session. I was very worried when I was sitting there, had a full audience to start. Now people are mostly headed out. But and please, Craig said, everyone use some question vengeance after I finish my talk. Do that, but be kind, okay? I'm going to talk about venous vasopressors today, and it's a emerging concept with early data, but certainly some very interesting data. So it's all about finding the balance, as you all have observed during the 2.5-hour marathon today. We started with norepinephrine, vasopressin, then we had the Angiotensin II mini symposium, and then went to metaraminol. But it's about finding the balance, right? And I've personally used this three-legged stool analogy for arterial vasopressor, saying it's balance between the sympathetic nervous system, the RAS, and arginine vasopressin. But today I'm going to take balance to the other side and also talk about the venous system, because in the end it's the balance between the capacitance vessels and the elastance side of the circuit to really see what we can do to effectively modulate circulation to our best advantage. Now, some of you have seen these slides before, and I owe Daniel Bakker some thank yous for sharing these slides with me, because they really describe well the normal physiology and help you understand what I'm going to talk about. This is the capacitance tank, the heart, and then the afterload side. This is sort of normal existence, and this is what happens when we have sepsis-induced vasodilation or septic shock. The size of the tank increases, and the tank size increases both the unstressed and the stress side. There is some compensation, but not enough. And then we give fluid in an attempt to fill up the tank. If we're able to do that, then we're able to maintain good cardiac output and forward flow and blood pressure. If we give vasopressors on the other side, we effectively constrict on this aspect, the afterload. We do decrease the size of the tank. So vasopressors, as I'll share in slides to follow, do have an effect on the venous side, but the predominant effect is on the arterial side. And that is what we worry about, because yes, you can go on very high doses of vasopressors and maintain a blood pressure, but in the end, there's probably an element of microcirculatory or flow failure that is damaging for our patients. And I cannot get away from the ATHOS 3 trial, so I'll share some sublingual microcirculatory blood flow slides that I don't know if I can play this here. These clips, can these clips be played, please, if someone can see me in the back there? On the left, if we could play that clip, is a patient in the ATHOS 3 trial who had normal blood pressure and we took this clip before enrollment, so no vasopressors, right? And if we could play the clip, you could see not just the rich microcapillary network, but the actual blood flow across the microcapillary network. Late septic shock, 3 vasopressors, same blood pressure, the effective blood pressure of a MAP more than 65, but really sluggish flow. And that is, if I go back, that is what we're worried about when we try and only give arterial constrictors in an effect to compensate for vasodilation and or hypovolemia is microcirculatory failure, and that's where we should think about the venous circuit. I was blown away when I came across this paper by the great Max Harry Weil, and as he writes in this paper, and this is JAMA from 1954, he writes in this paper that the circulatory failure clinically regarded as shock is primarily a defect of blood flow rather than a deficiency of blood pressure. So really, we're trying to increase pressure, but it is mostly about flow. And then he writes further on in this paper, and I quote, "By far the predominant mechanism is a fault in the capacitance bed." And then he writes further that the selective use of drugs to modify changes in the capacitance bed is a more promising and rational approach to therapy in shock. So he had thought about this 70 years or 75 years ago, that the capacitance bed should be targeted rather than the elastance bed. And in this same manuscript, he then talks about the agents that were available at that time, and then divides them into their predominant resistance versus capacitance effect. As you can see, most are predominantly acting on the resistive side of the circuit. Isoproterenol and mephentermine have a pure beta effect, so they're more inotropes than anything else, but do modify the volume of the capacitance bed. So that's where we were 75 years ago. Moving forward, we've sort of wanted to modulate the flow side of things, but we've never had the opportunity to do that. I'm going to also try and explain this using, again, Daniel and Anders Berner's really nice publication here. It is the venous stone that helps regulate the unstressed versus stressed volume. Most of the volume that sits in the capacitance side of the circuit here, in the setting of compensated hypovolemia, the venous stone will increase and will move unstressed volume to stressed volume, right? If the hypovolemia stays compensated, that movement is good enough to maintain forward flow. Once the hypovolemia becomes uncompensated, then despite the unstressed bed decreasing in size, there cannot be enough going onto the stress side, so the forward flow is decreased. On the other side, if there is vasodilation, that's septic shock, the size of the tank goes up, so you try and fill it up with fluids, but if you're behind, then you're obviously behind in your forward flow as well. So I thought this really helps you understand what I've just presented in terms of the overall physiology, but the bottom line again is that venous stone helps regulate this part of the important compensation. More detailed look at hypovolemic shock, because I'll be talking more about hypovolemic shock here. In the setting of hypovolemic shock, intravascular volume is going to go down, venous pressure is going to decrease venous return, and that's going to lead to preload blood pressure and cardiac output falling. In terms of corrective measures, we can either increase intravascular volume or maybe we can do some vasoconstriction. Right now, we're mostly trying to increase intravascular volume and give some vasopressors, which may or may not help with vasoconstriction all the way. So what's the problem with vasoconstriction? We have to have the right balance. So the right balance means the right distribution between the unstressed and stressed volume, hopefully less fluids if you mobilized enough from the unstressed to the stressed circuit, a stable cardiac output, at least hopefully increased cardiac output, and then less vasopressors to maintain the same blood pressure, okay? That's the optimal situation. If you over-constrict on the venous side, then high venous resistance will mean decreased pressure differential at the level of the capillary bed, a possible extravascular shift of the fluid, and then tissue edema and compromised capillary perfusion. So there is that balance we have to maintain at all stages. So what are our options as we stand here today? Norepinephrine, vasopressin, and angiotensin II. I will go over all of these. We've talked about them in detail today with an emphasis on the arterial side of the circulation, and then the newer agent, Santiago. So what about norepinephrine? Well, we know it does have effect on the venous side of circulation. This elegant work here shows that the level of the collecting venules is where the constriction is maximal as log concentration of norepinephrine goes up. Again, now going on to vasopressin here. Vasopressin also has an effect both on the arterial side and the venous side of circulation. It is a predominantly V1 effect, so giving the V1 antagonist takes it away. And then here, angiotensin II, also both angiotensin I and angiotensin II have a vasoconstrictive effect. And on the left side, you can see, giving captopril, that effect is attenuated. But it's important to remember that the predominant effect of all of these three agents is still arterial constriction and not vasoconstriction. And that effect in clinical practice does predominate in terms of what we see, at least at the macrocirculatory level. Santiago is not necessarily a new agent, but is now being tried out in early phase clinical trials. Its mechanism of action is a dual action. It acts both on alpha-2b and alpha-2a receptors, alpha-2b being on the venous side of circulation and alpha-2a at the central level. By acting on alpha-2b, it increases venous return, vasoconstriction, and increases cardiac preload. And by acting on the central alpha-2a, it causes vasodilation and a decrease in SVR, increase in forward flow. In this, in going back to what I initially brought up in terms of hypovolemic shock, this is where we stand. I talked about decreased intravascular volume and decreased venous return, and our corrective measures being either increasing volume or providing vasoconstriction. If there is the use of Santiago here, we can then use this vasoconstriction pathway to increase venous pressures and venous return and overall have a favorable effect on preload blood pressure and cardiac output, and hopefully decrease the total amount of fluids needed to maintain cardiac output, preload, and forward flow. So in an ideal world, again, this is going back to the initial slides I showed, hypovolemic shock, not enough volume in the tank. If you give vasopressors, you're just decreasing you're just increasing afterload, and you're decreasing a little bit of the unstressed, stressed volume side of the tank as well, but not enough. If you're giving Santiago, then you are decreasing and moving the unstressed to the stressed volume. You're actually maintaining forward flow and then increasing or maintaining cardiac output. So what does the data say? Well, the preclinical studies here in the pig model showed the safety and showed the effect of Santiago at the level of the peripheral alpha-2b and the central alpha-2a receptors. The phase 1, 2, and 3 studies have all been done in India. They're small numbers and the evidence is slim. But what we can see is that maximum tolerated dose and a therapeutic dose that is 0.01 milligrams per kilogram for a therapeutic dose, maximum tolerated dose 0.1 milligram per kilogram, a half-life of 0.7 to 1.5 hours. And then furthermore, in phase 2 and 3 studies here, improved blood pressure, lactate and base deficit, and then phase 3 study showing vasopressor requirement decrease, improved lactate, base deficit, and blood pressure, and a reduction in 28-day all-cause mortality. Now, I will say that the numbers here are small and studies are fragile, and this has to be repeated with appropriately powered studies to really make these conclusions. But I will show you some of this. This is a part of the phase 2 study where IVC diameter and cardiac output was looked at, and there was a substantial increase at IVC diameter at all of these time points. There was a correlation with increasing stroke volume as IVC diameter increased. This is part of the phase 3 data. The phase 3 data here showing systolic blood pressure being favorable for Santaquin, lactate being favorable, diastolic pressure also being favorable, and base deficit resolving in patients on Santaquin. Again, numbers are small, and these studies should be repeated, at least at the phase 3 level. There is an ongoing phase 4 as well, and this is some of the data from, unpublished data from the phase 4, showing a maintenance or increase in stroke volume and cardiac output, and then a maintenance of heart rate and mean blood pressure. And furthermore, here, an increase in IVC diameter. So what are our future plans with Santaquin? The most important future plans are that we have phase 3 clinical trials ready to be started in the US and EU. There is ongoing work with the EMA looking at appropriate endpoints for mechanistic goals here. The aim is to look at patients with hypovolemic shock, but not exclude those with septic shock, as that is also relative hypovolemia. The aim is also to look at patients with lung injury and ARDS. And we need appropriate endpoints, we need an appropriate sample size, we need patient populations that would be appropriate for these trials too. So this is some of the endpoints we're going to look at when we do these trials. We're going to look at tissue perfusion and cardiac output. We're going to look at days alive and free of organ system failure. We're going to look at microcirculation, need for overall fluid resuscitation, so overall fluid use during resuscitation, decrease in the requirement of vasopressors, and then mortality. One important study that we hope to start soon in Australia with Rinaldo's group is what we call the CORRECT trial. We're going to use Santaquin in a prospective manner to look at vasopressor-dependent vasoplegia and the effects of Santaquin on cardiac output and flow parameters. So, last slide, would a venous vasopressor help? Well, the ability to increase venous tone is really, really important. Get more stressed volume in the circuit, less fluid use overall during resuscitation, and possibly increase cardiac output with less need for vasopressors and maintenance of forward flow. Most contemporary vasopressors also act on the venous circuit, although the effects are negligible compared to arterial effects. And then alpha-2 venous regulatory agents, I talked about Santaquin as a promising agent. Lots and lots of work needs to be done, but the agent definitely has clear data that it supports vasoconstriction and maintenance of forward flow. More to come in the years to follow. Thank you so much for your patient list.
There's a plenary talk here in 8 minutes, so we have, I guess I'll ask you my question privately, Ashish. We have time for one question over here, and then everybody either needs to stay for the plenary or clear out for the next people. Have at it.
Hi, thank you for a splendid presentation. I'd like to commend you for highlighting that venous return and venous physiology is key to understanding circulatory management. That's fine. However, I'd like to challenge you. In my research, in my clinical practice, I have been taught that veins are a main site for alpha-1 receptors, and specifically that the alpha-1 receptor density is absolutely highest, not in the arteries, but in the splanchnic veins. I thought that was the case. Do you have any experimental evidence against that? I would say norepinephrine is a perfect vasoconstrictor in the veins.
Yeah, no, that's a great point. And I agree with you that norepinephrine is a vasoconstrictor, but in case of norepinephrine, the arterial constriction is going to predominate because the alpha-1 receptors are on the arterial side as well, right? So in case of Synthequin, there is no arterial constriction, and there is theoretically at least decrease in central alpha-2A flow, so there is an element of vasodilation, if anything else. In clinical use, I would say Synthequin would need to be combined with norepinephrine, okay? And I didn't touch on all of that, but I think once the agent is available, it would need to be combined with norepinephrine in clinical use to maintain both a vasoconstrictive effect, hopefully get some of that from norepinephrine as well, but also to have at least some element of arterial constriction to maintain perfusion pressure. And I hope I've answered some of your question at least.
A truth in life is the final word should always go to Jean-Louis Thibault.
Yeah, so maybe a last question to Ashish. Just not to bother you, but are you aware of some down-regulation of the alpha-2 receptors in some critical situations, like down-regulation of the alpha-1? You refer to norepinephrine, and are you aware of this kind of down-regulation, meaning that maybe it cannot work as a vasoconstrictor in some situations, like sepsis, etc.?
Jean-Louis, great question. As always, again, clinically, I think we still need to look at all of that. I'm personally unaware of those situations where there would be downregulation of the alpha-2 receptors, specifically on the venous side. Again, once we do further experiments, we'll probably be able to answer some of that. Thank you.
Okay, so I think it is time to conclude after 3 hours and 34 minutes. It is like a marathon because I was a marathon runner. It was exactly the time I ran the marathon, my best record. And so thank you very much for your attention and your participation. Thanks to the speakers.